Right, 1 minute warning, everybody. Nick, you're over here. And Moira on this side, I think. I think you're there somewhere. Right, good morning, everybody. Are we ready to start? Right, dead on time. Let's kick off. Good morning, everybody. Just a reminder, we are live streaming, so the usual policies and actions in place. That would be very helpful. This actually is the last meeting of the Suffolk and North East Essex ICB in Colchester, which is really sad for us, and also the last meeting in this beautiful building, because it is fantastic, isn't it? So let's make the most of it. We've got a very big agenda though today, so we'll have to crack on. And Nick, if I just may say, I think this is your last meeting, and we'll be extending thanks to you for everything you've done, but I'm going to let Ed do that as part of his presentation. If you well, nor me. But thank you, and enjoy retirement. So some quick welcomes, if I may. Rory, Lynn Stimson, Andrew Urquhart is here, Wendy Scott, and Sarah Bargent, and Helen Bowles. You're welcome to the meeting, and we look forward to your contributions. Thank you in advance. Apologies we have from Lisa Nobes, but we have Sarah deputising, thank you. Caroline Donovan, but we have Kath, as always. Gareth Everton and Clement deputising, thank you. And apologies this morning from Susanna Howard, who's not well, so we wish her well and recovery. And also from Mark Burgess. Did I miss any? Okay. In which case, then, let's move on to questions from members of the public. We do have some advanced questions from Mike Hope on data apprenticeships, 4 questions from Anthony Dooley, and 1 from John Ray on dentistry. I'm proposing to take them all at the end of the meeting, unless, I think, Maddie, you might deal with a couple in your presentation, and we'll test that as well. So if you have, we'll spot that and deal with that appropriately. Any others, Tom, that I should be aware of? No? Okay, in which case, declarations of interest. Are there any declarations of interest or potential conflict of interest with any agenda item, other than those of which we're aware, of course? No hands raised. Then let's go on to minutes of the last meeting, 23rd of September. There's a bunch of pages there. I don't propose to turn the pages with you unless you want me to. Can we do them for truth and accuracy first, please? Has anybody got any points of accuracy they'd like to raise? Nobody's suggesting they have, so shall we take it that the board resolved to approve the minutes of the 23rd of September as a true and accurate record? Everybody content? Agreed. Thank you very much. Then let's go on to item 5, the matters arising. Now, apart from 2 items, as far as I could tell, they were all complete or not yet due. The first of my 2 items, I think the second one is for you, Elaine, I'll come to you. The first one is the action to do a deep dive and board development around ambulance call-out performance, C1 and C2. which I believe, I'm looking at Tom here and Richard, I think we believe would be better done in May after winter performance, so that we get a proper reflection of the whole year performance, and to also allow us then to plan for winter 26-27 better. Is everybody content with that? Thank you. In which case, Elaine, could I come to you?
Yes, it was just at the last meeting we did note a specific action regarding a future update on the sustainability work, including productivity. And whilst I'm sure there are other discussions going on in that, we did say we would bring it back to the public board meeting. So I think it'd be good if that could just be an action that we bring back to a future one.
Thank you, Elaine. Tom, happy to put that in the forward planner. Everybody content? Thank you very much. In which case, are there any other issues in the matters arising that people would like to comment on or seek clarification of? All agreed, so we approve the matters arising and the actions taken as presented, subject to those two comments. And then, final point on matters arising, does the record that is before you capture the matters arising that you thought it should, or are there any others? All agreed, true and accurate record. Lovely, thanks very much everybody. In which case, item 6, CEO's update. Over to you, Ed.
Thank you, Chair. Good morning, everyone. So before I get into my update, I've added a very important letter that we received from Sir Jim Mackey and Joe Lenihan around requesting action on racism, including anti-Semitism, asking all organisations, all leaders to reiterate a zero tolerance stance to all forms of hatred, anti-Semitism, Islamophobia, racism, or any form of discriminatory behaviour. So I know as a board we take that stance very seriously, and we talked about some of these issues at the last board. But Amanda, do you want to just say how we're taking forward the letter locally within our system?
Indeed, thank you very much, Ed. So as you say, we are taking this very seriously, as we would on all things EDI. So in response to the letter we received a few weeks ago, we have got in place a number of actions. So number one, we are taking the letter to both of our people committees early December, because we feel that as a strategic commissioner, we need to be assured that our local providers are actually acknowledging and actioning the letter as laid out in front of us. So that's the first action that I would like to inform board on. The second is that we already have it diarised for our in-common REMCOs as well, because we feel it's a matter that we need to be sharing with our REMCO and obviously sharing with them the anticipated action. And in terms of the current, I felt it was appropriate just to remind board that we actually have mandatory training on this item, or the broader EDI, for all of our staff across the ICB, and we currently have a compliance of 95%. More work to be done, but we are working that through with our networks and the like. We also have it as part of our core induction for our new starters, and that will remain as we move forward. And in relation to the particular points within the letter, we are still awaiting the further updated mandatory training that they refer to, which we expect to receive in 26. So once we have that, we will clearly be wanting to implement and actually underscoring the importance of that, and actually ensuring that all of our staff don't wait until the end of their current 3-year cycle in which they have to do EDI training, but we'll be making sure that everybody has the updated mandatory training which references this from day one. So that information is still awaited, but once we have that, I will update the board and the appropriate committees thereon in.
Thanks, Amanda. Any questions on that? Elaine?
Yeah, so I think, first of all, I thought the letter, first of all, it's disappointing that there has to be a letter like that, but given it's been stated, I think it's really good and very strong. I particularly liked re-emphasising the point everyone should feel safe, valued, supported, regardless of background, faith or identity. So very supportive of that. I thought it was interesting the point about the shift to mandatory training, because I appreciate Amanda said that the ICB covers that, but I did just wonder, do all of the NHS organisations already cover that as mandatory? It'd be just interesting to know, or if that will be a big shift come April.
That's a really good point, isn't it? Shall I hold you, Amanda, and go to Nick and Fanwell and then come back to you? Nick?
Thank you, Chair. I mean, I can only speak on behalf of VESNEF, but we certainly do have this in mandatory training.
Yeah, thank you. Fanwell?
Thank you, Chair. I think it's quite positive to hear that we're focusing on training and particularly mandatory training. We've been hearing quite a lot from communities, and people are expressing concern and in some cases fear about the current obtaining environment. And I think we need to think about how we can go beyond just the mandatory training and actually look at, being vigilant, being proactive, and making sure that colleagues feel that sense of belonging. And I think it's incumbent upon all of us to ensure that we are sort of looking out for colleagues.
That's a great point. I mean, as well, and part of our overall philosophy always, isn't it, to go good isn't good enough. We want to go to great. But do you want to comment on that, Ed, at all?
Just fully endorse it, and let's work together to go a step further than mandatory training, definitely.
Great, thank you. Amanda?
Yeah, thank you very much, Chair. So just building on what Fanwell said, I think that is an excellent point, and will play into our wider organisational development programme as we move forward in terms of a new organisation. But I think it may be something that we, as potentially a new board, may consider as something that we would wish to have a board development on as part of our ongoing commitment to the broader equality, diversity and inclusion agenda. So just something we may want to come back to, but...
Sounds good, and I saw a lot of nods around the table. Tom, should we put that in the forward planner? Thank you very much. In which case... Clement, yep.
Just really important to recognise that the priorities around EDI will sit with a number of partner organisations. So where we can collaborate, I think that would be really beneficial.
That's really good point. And yeah, not only with a number of organisations, but actually with all organisations and all of us. It's a organisational and personal responsibility, isn't it, if we're going to get this right. So thank you for that, Clement. Any other points? Otherwise, I'll go back to Ed. All yours, Ed.
Thank you, Chair. So probably the dominant issue within the organisation at the moment is around the staff consultation. We'll be talking about that later, but just wanted to thank all the staff for their professionalism at what is a really uncertain time, and Amanda and team for the diligent way you're managing the consultation and leading it, I think, in a very transparent and fair and open way. Thank you to colleagues within the system. We've had a resident doctor strike since we last met. I think we maintained over 95% of activity during that period, so thank you for that leadership. I was really pleased to see that we're the first system nationally to use AI to diagnose chronic obstructive pulmonary disease. There was an excellent ITV Anglia report on that. I think that's being rolled out in North East Essex. It's then coming to Suffolk, and then the intention is into Norfolk and Waveney too. So really exciting that the diagnosis now takes 5 minutes compared to a much lengthier time with spirometry. The national neighbourhood implementation work is progressing really well. We've launched the care management service in West Ipswich, which is one of our more deprived communities, and there's an intention in our commissioning intentions, which we'll talk about later, to look at that at a wider scale. An integrated diabetes service is coming forward as part of the West Suffolk work, and excellent work on managing rising risk in North East Essex, so really, really good neighbourhood work underway as part of that national programme. We'll hear about the new GP estate at the Hawthorne surgery from Rory very soon, but we're progressing as well with the redevelopment of the Inkerman site in Ipswich, which is getting closer. And in terms of general practice, the Glemsford surgery, which was previously run by the West Suffolk Foundation Trust, is now going to be merging with Unity Healthcare run by Suffolk GP Federation, which I think will bring together a site in Haverhill, Glemsford, Lavenham, and there's another site, my memory fails me, Long Melford. So very good to see collaboration at scale in general practice. We have a new ambulance hub that's opened on the Ransons Industrial Estate in Ipswich, which is a 12 million development. I know, Maddie, you were there for the opening. There's a similar hub that's opened in Bury St Edmunds as well. So really fantastic that Suffolk's received that investment. We're performing really strongly in our vaccination programme. I think there may well be some data in the pack today, but both Suffolk and North East Essex and indeed Norfolk and Waveney, I think, are right at near the top nationally in terms of their performance. The Jaywick Sands Healthy Homes team has been awarded an outstanding achievement as part of the National Healthy Housing Awards 2025. And this is a brilliant collaboration between Tendring District Council, the ICB, local GPs, Essex Fire and Essex County Council to improve the quality of housing stock in Tendring. And then on to people. So congratulations to Dr. Tanvir Alam, who's our Deputy Medical Director working to Frankie. He's been secured the position of Chair of the Asian Professional National Alliance, as well as a position on the ICGP Board. Tanvir, I think, is an incredible leader, and the work he's done around cultural safety, reflecting back on your points about fear just earlier, is amazing. So all power to Tanvir's elbow. We're really proud of everything he's achieving. We have a new Chancellor at the University of Suffolk, Zeb Soanes, who's a broadcaster. Some of us may know from the BBC Proms, Classic FM and BBC Radio 4. I think Seb's from Lowestoft, so he's a local man, and I'm sure he'll do an excellent job as the new Chancellor of the University. And then finally to Nick. So what to say about Nick? Where to start? So Nick and I have both been in the system quite a long time, over 10 years, and have enjoyed such a close friendship and partnership. I think when I started, Suffolk was described as Sleepy Suffolk. And in the health service, I think Nick's done more than anyone to shed Suffolk of that tag, really. The drive, the ambition, the energy, the passion for tackling health inequalities really shifted the culture very quickly. And Ipswich Hospital, when Nick took over, was a sleepy organisation, and I think that changed pretty rapidly for the better in Suffolk. He was then asked to take on Colchester Hospital, which at the time was described as the worst hospital in the country, and that turnaround for the community happened at rapid pace. The two trusts were brought together, I think, in one of the more successful mergers in NHS history. The community services came together under Nick's leadership, both in North East Essex and in Ipswich and East Suffolk very effectively, and we have a genuine integrated trust, which is very much part of Nick's vision for healthcare. Nick established with Susanna the STP back in the day, and I think set the DNA of the system around health inequalities and what you described as higher ambitions, which I think are still highly relevant. Nick led on the national vaccination campaign during COVID, which I think led to one of the things that led to his recent well-deserved honour, and in most recent times has rolled out EPIC for ESNEFT, which is an incredible gear change for the whole system, not just the organisation, and have done it in one go, which I think is unprecedented, and done it so successfully. So I could go on and on about Nick, but what a contribution to the population in this system. He's also contributed, as I said, nationally, and made a big impact at Norfolk and Norwich in recent times as well. So the list goes on and on, but what a partner, what a friend. We always said we would never fall out over money, and over 10 years I don't think we have, which is surprising for a commissioner and a lead provider. But we're so proud of this contribution, Nick, and congratulations on everything you've achieved.
Oh, thank you very much. Nick, very well deserved. And would you like to respond?
Yeah, just a couple of words. If I mean, first of all, and most importantly, Chair, you won't have to remind the board at every meeting quite so often that we're being live streamed. Just saying. Some of you with long memories. Anyway, so it's been the privilege of my career to work in this system. I'd never been to Suffolk until I came up for the interview at Ipswich Hospital. And I was told by somebody very senior in the NHS, all you need to do is come up to Ipswich, just manage it for a couple of years. You have to be an FT, so you'll either be taken over by Colchester or West Suffolk, and then you can retire and live on the coast. Right, not quite how it worked out. And I'm very pleased that it didn't work out that well. So I just want to commend everybody, all of you who work so tirelessly as a system. I think when I talk to colleagues up and down the country, national colleagues, and I've always said I think this is the blueprint of system working that we've developed, across both counties really, but particularly under Ed's leadership in SNE. And we are facing, I think, the most difficult time in health and care. I think there's an existential threat to the future of the NHS. I genuinely believe that, and I've never said that before, but I think if we look at the political powers and the shift of political thinking towards extremes of individuals and parties that don't believe in the NHS, we need to be very, very careful that we as the NHS don't give them ammunition. So I think now is the time more than ever for us to come together to focus on what's important for our communities, to have courageous conversations with our colleagues, with our staff, because without those courageous conversations, things won't change. We have to look at the use of technology. We have to look at individuals and professions working differently to achieve change, because one of I believe the greatest thing about living in this country is the NHS. But I also believe that having a state-run monopoly as a health provider carries with it a risk as well, in terms of affecting good change in the long term. So thank you for all your friendship, for all the good times and the not so good times, for everything that you do every day for the lives of the people that we serve. I think often, particularly people that work out of the limelight, behind the clinicians, whether in primary care, mental health, secondary care, tertiary care, you often don't get the credit for the extraordinary work, professionalism, tireless effort that you put in every day to make a difference to the lives of the people that we serve. We don't say it often enough, but I want to say it very publicly now. Thank you for everything that you do, because you do make a difference. You make a difference to thousands and thousands of lives every day, particularly to the lives of the most vulnerable. So thank you. Thank you, Chair.
Thank you very much. Nick, thank you very much, and thank you for those lovely comments as well, which I know everybody will appreciate. So thank you so much for that. And we wish you well in what might not be retirement, Nick. This might just be the next stage of your career. Who knows? He's shaking his head. But thank you for everything. Okay, colleagues. Ed, did you have anything else, or are you done there?
I'm done.
Okay, in which case, any questions for Ed on his update, or are you content that we move on? In which case, let's move on. So item 7, the Heart of Greenstead project update. Rory, now the last time we met and discussed this, I think we were at the University of Essex, were we not? And we had a fantastic presentation, and I know the board was really energised and enthusiastic about the work. So because this is our last meeting, unfortunately, in Essex and Colchester, great opportunity to update. All yours, Rory.
Thank you, Chairman. Good morning, Board. I do have a tickly cough, so just warning you. I've got my water and my cup of tea, so hopefully that will keep me lubricated. It was May, I think, I came and presented to Board. I think Board will recall I brought some colleagues, brought the team with me that time, including members of the community and ward councillors. I'm on my own today, but hopefully I'll do the project justice. So, again, for people who don't know me, I'm Rory Doyle. I'm Strategic Director at the Council and Associate Director within the Health and Wellbeing Alliance. And this is a project that's really close to my heart. So I was just going to give a bit of an update because it was May we last spoke. Lots has happened since. I thought it would be good just to do a bit of a refresh and a reminder, because even since May, I think the significance of what we're trying to deliver and grow through Heart of Greenstead has kind of taken on even more prominence with everything else that's happening. I've got a few slides just to help me. So as a reminder, Heart of Greenstead is a regeneration program in Greenstead. For those of you who don't know it, it's kind of a suburban area just outside the main city centre, predominantly kind of social housing. It does benefit from amazing community facilities, but they're tired. They're not really kind of connected in terms of how services are delivered there. And I think I shared with you, honestly, the sense that we get as institutions and organisations supporting that community. There's been a degree of mistrust in terms of work that we've done over the years to try and fix that community. So from the outset, we've tried to take a really different approach. And as I say, the council has benefited from investment from the government through the Town Deal programme, of which £6.5 million was directed towards Greenstead. So this is a capital programme. It is about investment in the infrastructure, and we've been able to leverage further funding alongside that government investment to make it go further. But I think, as I shared last time, this isn't really about buildings. It's about the interconnectedness with the community. It's about how we as organisations and services develop new relationships with the communities we serve, and more importantly, how we shift power and agency to that community themselves. And of course, you'll all know we can't have a conversation these days without talking about local relational health services and neighbourhood health. And behind the buildings and the investment in the infrastructure is the development of a model of how we as services, agencies and organisations work better together. So it's really important, but interwoven with the strengths and the assets of the community. So just moving on. Again, I'll probably emphasise this. So it's a strategic priority for the council. Absolutely, it's part of our Town Deal programme. But as I said, we've been really conscious to kind of leverage it into our wider work. So we've also benefited from investment from Sport England for it to be a kind of an active development, both in terms of what we bring forward through future infrastructure, but also, and I'll talk about it in a moment, we've had a part of the project is the provision of free bikes, so a free bike scheme to residents within Greenstead, and we've had some amazing outcomes associated with that. Bikes, on the face of it, again, a physical activity intervention. It's not really. The bikes are a currency. It's about making better connections with the community, and it's a sustainable model that's amazing. And I'll talk a little bit more about some evaluation we've done on that in a moment. Heart of Greenstead is one of our key sites within our neighbourhood health implementation programme. So it's one of the main ones we're focusing on in terms of convening our neighbourhood teams together. And I guess what importantly this project gives us the opportunity is how we weave that into the wider kind of social and community fabric and the other organisations that exist at a local level. So really getting the broader value of what neighbourhood health is like in terms of certainly the wider determinants of health. You'll all be familiar, and many of you were involved with the Caring Communities Commission recommendations. If we deliver Heart of Greenstead in the way that we intend to, it absolutely acts on some of those recommendations in terms of new models for care within the community. We've benefited from, and you will have heard recently, there was in the press and media, Greenstead, alongside some other places in Essex, has benefited from further investment from government. So 20 million over 10 years through the Pride and Place programme. And what we have with the Heart of Greenstead project, it gives us an amazing platform now for further investment and kind of to sustain what we've started, building on the excellent relationships we've developed with communities. And the other thing, I guess, that we're really conscious of with the Heart of Greenstead is, it's not a typical regeneration project. We don't have a typical regeneration board. We have members of the community as part of that. They're absolutely interwoven with the decision-making, real diversity in the decision-making. And of course, that's a real emphasis that's come through the Pride in Place programme. This is about, again, kind of power and agency with the community. And I've mentioned local government reorganisation. I'm in a joint role at the moment, and alongside all the changes going on in the ICB, local government reorganisation is dominating my world. But of course, what an amazing opportunity we have. And this is just an example of how we can design new models to better serve our communities. And I've kind of emphasised there the synergies around all of those work programmes in terms of shifting power and resources to neighbourhoods, integrated prevention services and tackling stubborn inequalities. So what have we been up to? More importantly, this is probably what you're interested in since we last met. So we had an amazing Greenstead Summer Festival with the community, brought groups, agencies and residents together, and we just had fun, which was really, really important. Continuing to build relationships, build trust and talk about the work we're doing. Ed's already mentioned it. So I think in May when I last met, we were about to commence works to Hawthorne Surgery. Those were complete with the opening on the 18th of October, so delivered on time, on budget. I think it was just over £500,000 investment from the ICB. So we've managed to extend the existing Hawthorne surgery into a vacant kind of void space next door. So much greater capacity, additional consulting rooms, additional community room, additional staff rooms, so better facilities for staff. And as I say, that was delivered on time, October the 18th, grand opening. And I know I spoke to Nikki Young, the business manager there, and the feedback they've got from staff and patients is great. Other work, as I said, we've been really successful leveraging funding into the heart of Greenstead throughout. We've managed to secure some additional capital investment from Sport England to kind of weave in opportunities for physical activity provision within the build itself, and we're working with the community to understand what they would like when we bring forward the refurbishment to the community facility and library and children's hub itself. We've established a bike kitchen in Unity Primary School, so again working with the assets that exist in the community already. And then some of the big things in terms of the actual project, the design and build of the project. We got planning consent agreed this month, and just as a reminder, that's for an extension to the existing community building, which is kind of that top image you can see there, which will bring Greenstead Library alongside the community facility. It provides amazing space for local services to be delivered, but more importantly, just for the community to connect, come together and use space themselves. Alongside the community building you see there, we're also redeveloping the existing library building. The current library function will move into the building you see there, and the library building will be repurposed as a children's hub for Greenstead, which again, we heard really early on in the insight from the communities that we need to do more to support families and children in Greenstead. And throughout all of this is space for organisations to come to work together and integrate and work alongside the community. So we're just in the process of completing the procurement for the contractor to undertake the build and finalise the designs. I can't give further detail on that because that's subject to a decision at our cabinet in December. But there'll be more information in the media shortly. But that's a key milestone for us to be contractually committed, which was a key requirement of the grant funding. And actually, just right down the bottom there, I'm looking. So I've mentioned Essex Pedal Power, which is the free bike provision scheme. We were really fortunate. So alongside Pedal Power, there are other free bike schemes in the UK, and through Sport England, we commissioned an independent evaluation of the economic benefit, health benefit of free bike provision. And we had a House of Lords reception last month to kind of launch this evaluation. I mean, no surprises, for every pound invested in this scheme, it's delivered £12 payback to the community, and actually that's a really conservative estimate. We know it's considerably more than that. I pulled these slides together last minute. I should have another one that says what's next. So you probably would understand we're getting into the finalisation of the contract to get the builder on site. We hope to complete the contract arrangements by the end of January. The final designs for the community facility and library will be finalised end of May. We aim to be on site and start spades in the ground in the summer, and it'll be about a 56-week build, so about a year where we'll be on site. And so, yeah, next summer, well, some are beyond the next one. Hopefully we'll have these amazing facilities up and running and supporting the community. Happy to take any questions.
Rory,
That was a
thank you.
whiz through.
Thank you very much. And you know how much this project means to us all, and we know how much it means to you and the communities. And Rory, well, I was going to say 3 words, but one of the 3 words is 3 words in itself, which sort of impacted me. But integrated came over really clearly. Thank you for that. Impact on the wider determinants of health, really positive, and then social, economic benefits and so on as well. And then neighbourhoods, and that obviously is a great segue as well, I'm sure, into Maddie's next item. But are there any questions for Rory or points that people would like to make? If not, shall we simply recognise the achievements to date? Thank you to Rory and actually the wider team as well. And thank you for the contribution and in a way legacy that you're leaving this board as we move on into the new structures going forward. We'll certainly miss hearing about this project over the hopefully years to come, Rory, but perhaps we'll come down and visit you, who knows. Okay, so thank you very much, and thank you for the update. Good luck for the future and the future delivery.
Thank you, Chair. And I have to give my apologies for the rest of the meeting. I've got another board meeting to get to, so apologies, but thank you.
No, that's no problem. Thank you very much for coming. We appreciate that. So, thank you, Rory, and great segue into item 8, Maddie, National Neighbourhoods Health Implementation Programme. All yours.
Thank you very much, and thank you also. It's been slightly trailblazed. So we are really pleased that North East Essex and West Suffolk and Ipswich and East Suffolk alliances were all successful in being included in the National Neighbourhood Implementation Programme. And what this programme does is to support us through national coach and national networks and shared learning with peers across the country and within our own teams to drive forward our local ambitions and those that are for national neighbourhood health development. So we are 3 of 43 across the country, and it will enable us to further push forward in demonstrating progress towards the 3 shifts which are in the 10-year plan of hospital to community, of analogue to digital, and illness to prevention. So I think we're very fortunate to have very firm foundations to be part of this programme and to move forward. And what we've been asked to do with our alliances is to focus on specific cohorts of the population so that we can really demonstrate in quantitative and qualitative terms the benefits that working in this way as a team, as neighbourhood teams, and with the support of alliances in their places can have to people's lives. So this is a learning exercise, but it's a very practical one as well. So each of the alliances has identified 18 colleagues to be wholly part of the programme and to represent their organisations and patients and the public, the voluntary sector, our acute community and primary care partners are part of the 18 in each of our areas. And we have each proposed a focus, and so as was mentioned in North East Essex, based on previous work, they'll be focusing very much on the 5% of the population who currently need the most care and resources from all of the providers within North East Essex. So it's a very holistic approach, it's a very evidence-based approach, and it will be working very much with small teams within the neighbourhoods to try and look at the needs of those individuals and to develop personalised plans for them and with them, and to develop a holistic response which may be delivered by health or social care partners, but may also be delivered within the community and by the community. So that will be the focus for our North East Essex teams. In West Suffolk, the focus is going to be on diabetes. So overall, across the whole of Suffolk and North East Essex, diabetes outcomes are good. But there is variation, and we know that this is a particular focus that colleagues in West Suffolk would like to drive forward to ensure that care is wholly optimised across the whole of the pathway from prevention through to secondary care, and moving that into the community as best we can, recognising still the specialisms which must be delivered with and by our acute colleagues. So we'll be working together on that, and that's also very important in terms of the future estates challenge that exists within West Suffolk as well. So we'll be looking at how we can progress that together. And in Ipswich and East Suffolk, Ed's already mentioned the 1% programme of work, and that will continue. We're very much in a learning phase in West Ipswich at the moment. So we hope that that will provide learning for us to roll that out further across the whole of the area. And we're also looking at heart failure. And heart failure may sound initially as very much a secondary care business, but we actually think this is absolutely everybody's business in terms of prevention, in terms of recognising the signs and, of heart failure, and in terms of the work with primary care, with community organisations, with in fact our social care colleagues, and as well as with community services who have some specialist heart failure services, and with our secondary care colleagues. So we're working up these plans. There'll be very clear implementation plans for each place in order that we can drive forward together and to try and really make a difference to prevention and to holistic care for the individuals within these cohorts. And as we move forward, we hope to learn together, one from another, and with our colleagues in the rest of Essex, and with our colleagues in Norfolk as well. So this is truly a learning by doing and a learning together programme. So that's where we are today. There's a great deal of work to do, which we're very positive about. We will be reporting, of course, to our Alliance committees, but we would also be very pleased to bring back reports of our progress to the boards. So I'll pause there. If that's okay, I'm very happy to take any questions.
Maddie, thank you very much. And I'm sure board members will appreciate a quarterly update, so let's take that as agreed, unless anybody thinks that's not a good idea. Let me go to Elaine and then to Ed and Frankie. Okay, Elaine.
Okay, so first of all, thank you very much, Maddie. I mean, it just is a really exciting initiative, actually, as you say, and I think the fact that it's focusing on specifics and looking at evidence is really good. I just had a question, and it may be too early to answer this, but it was interesting. I noticed in the paper it talks about the having measures on patient outcomes, the POMs, and also patient experience, the PEMs, which is good to see that it's both of those, that it's looking at the experience as well. So it's not just from an organisational lens, it's from an individual person lens. Is it possible to just give some examples of what those sort of measures might be that you'd be looking at, or when they'll be defined? That'd be helpful, thank you.
Thank you. So I think we will be defining those together with the patients, with the cohorts of, or representatives of the patient cohorts, as well as using some of the standard outcomes that we hope will be achieved through this, which will be not only related to prevention, but also to the reduction in need for some secondary care services, for example, reduction in emergency presentations and emergency admissions, because we're kind of moving ahead and we're being proactive in the care that's being offered, and because we're joining up. So I think there's still work to do, both to agree those in each area and also to put in place some trajectories, because I think what we'll all want to know is, are we winning? Are we making progress for the people that we serve? Do they feel that difference? And do we see and experience that as well as teams? So work to do. Thank you.
And before I come to Ed, Elaine, do you mind if I just add a little follow-up on that? So, will success and evidence of success and defined outcomes be part of the implementation plans that are in progress?
I mean, we have reached these, maybe I didn't say enough about that at the start, but we have reached these proposals for the focus, both through the very detailed information that's available to us from Richard's team, so business intelligence and population health management, together with the insight from colleagues working in the alliance areas. So this is really both data and insight driven as a programme, and that's what we will need to sort of flow through as we implement.
And to enable success or otherwise to be measured.
Exactly.
Happy with that? Yeah. Thank you, Maddie. Ed?
Yeah, thanks, Maddie. Great progress. Just wanted to stress it's really helpful that the different alliances are testing different approaches, and if we added in the 3 places in Norfolk and Waveney, there's a similar themes, but all doing things slightly differently. So I think the next step is how we formally bring the partners together in the alliances, just to make sure that everyone's learning from each other and that everyone gets the benefit of the progress being driven. That's a sort of a slightly rhetorical question. The second point is that in the news today, the Treasury are going to support I think they're calling it the NHS Community Rebuild Programme, which is around allowing use of private investment to build new health centres in communities, which is an interesting opportunity, but my reflection from listening to you and listening to Rory is this is really about culture and focus on conditions, isn't it, and communities, not getting fixated on buildings. So it's just a sort of word of caution.
Thank you, Ed. Go on, Maddie.
Yes, thank you. And I think that gives me the opportunity also to answer the question that was asked directly. So in terms of the physical assets of neighbourhood health centres, which wasn't quite the focus of this paper, as you said, Ed, this is very much focused on services and working together and integrating for proactive care. But buildings are important, and led by Amanda's team, what we're doing at the moment is to map all of the services in all of the assets which we have already within our communities. So looking at primary care facilities, our community hospitals, other buildings from, that may be owned by the voluntary sector or owned by our local authorities. And we're looking at those very systematically and understand who is already working together in those buildings and where there are potential opportunities for more services to be co-located to fulfil the vision of neighbourhood health centres, or where actually it might be really good for moves to be made that will enable people to work differently and better together in the future. So we're doing that integrated neighbourhood team by integrated neighbourhood team. And I think what we can see, even from those very early reviews, is that there are some buildings with services working together in them today that look very much like the vision of a neighbourhood health centre, and that is likely to be a really positive building block and potentially a financially very efficient way to move ahead. So that work is underway to understand where we're at with assets. Thank you.
Okay, thank you. Frankie?
Thank you, Mandy, and thank you for leading such fantastic work. I'm going to make one of those annoying comments that isn't really a question. Apologies in advance. You mentioned, Elaine asked you about the outcomes, and we're talking about the impacts on individual patients, how they experience it, but you also referenced the financial outcomes in as much we're hoping that this work will reduce emergency demand, which is great. But I just wanted to flag the other huge underlying reason for this work, which is to address health inequalities and the specific areas that we're focusing on. Diabetes and cardiovascular disease are the biggest health determinants of health inequalities. So taking aside the wider determinants, which are obviously well documented, but in terms of health, they go together as well. Diabetes, obesity, cardiovascular disease, They are why people living with deprivation are living less healthy and less fulfilled lives. So it's really, really important that we do this to reduce those inequalities.
Thank you, Frankie. I think we'll take that as a yes, thank you for making the point, Maddie, if that's okay. I'll come to you in a moment, Frida, if I may. I've got Chris first, and then Frida, and then we'll try and move on. Chris?
Yeah. Thank you, Maddie. Just a suggestion. Diabetes UK, I'm aware, I'm a trustee in Diabetes UK, and they are looking to partner with ICBs to collect evidence, and there is some funding available. And that would be a good way to partner. I mean, if you wish, I can make the introductions, and they are definitely looking to collect evidence and do the partnership.
Thank you. I think what I'd like to say to that. Yes, please.
Can we take that as an action that you two catch up after the meeting? Thank you very much. Thank you, Chris. And Frida?
Yeah, I just want to go on Frankie's point a little bit. It's that the 5% model in North East Essex is an inequalities model, if you think about it, because it does address that top 5% of highest need. But also, the only thing that I'd like to just point out is, in terms of neighbourhood health service, which is what we're moving towards, these are excellent, by the way, Maddie, thank you, all three. But it's just that we, you know, when we work in alliances, we have different providers around the table, and we're all very good at talking and being collaborative, but then we go back to our organisations and sit within those boundaries and restrictions that those boundaries put on us in terms of our provision of services. And I think in terms of the culture, which Ed brought up, the culture needs to change, and we need to, in order to get a true integrated neighbourhood health service, we need to change the culture that we break down those organisational boundaries and we work more together, and I think that multidisciplinary approach would allow for that, but it's about emphasising the need for it within our communities of staff and things, because otherwise it's so easy to sit in your organisational boundary and not move outside that. That's what concerns me in terms of the health service.
Thank you, Frida. Do you want to respond to that, Maddie?
Yes, I mean, I think we're very optimistic and positive about this. This is not going to be without challenge in terms of exactly the things that you described, Frida, in how we work, where we work. It will, I think, stretch us. I think there will be very challenging conversations about how we can really make the scale of difference at the pace that we know we need to. And this will mean working differently for everybody. So, yes.
Thank you. So, colleagues, would it be fair to say that the board is actually asked to receive a note, but that we endorse the modus operandi? We're excited by the possibilities, and we look forward to delivery and outcomes in the way that we've discussed, and we would like quarterly updates as offered. Agreed? Lovely. Thank you very much, everybody. Thank you, Maddie. In which case, then, could we move on to item 9, which is the winter plan update? And Richard, all yours.
Thanks, Will. So there's a short paper in the pack which just provides the board with a brief update on our winter planning. You recall at our last meeting that we brought and you approved our winter plan for 25-26, and that was subsequently signed off by NHS England as part of their assurance process. NHS England consider winter commencing on the 1st of November, so we are in winter, and that running till 31st of March. It feels it, to be fair. I think it's fair to say, and I'm sure Nick, you and Kath and others would agree, that it's been a challenging Q3 in terms of the demand pressures we've seen on all services from primary care through all. And particularly, I think, just to commend again Nick in terms of the EPIC rollout, in terms of the challenge that yes, there's been challenges, but the scale of that could have been much more challenging than it has been. And that was obviously running over the last few months as well. You'll see at section 2.4 that the East of England collectively is currently tracking around last year's trajectory. But we are particularly challenged in Suffolk and North East Essex around our patient handover delays between the ambulance service and ESNEFT, and we'll cover some of that in the performance item later on the agenda, but Nick might want to comment when I close. And we've also seen particular challenges around mental health in Essex specifically. I'm sure colleagues will touch on that later on in the agenda as well. If you go down to section 3.3, we have had some internal capacity challenges around our Command, Control and Coordination Centre. So we are seeing a change of overall leadership in that function with Liz Maloney, who has got a new role working over in ESNEFT. So I've just put a record congratulations to Liz in terms of moving on to ESNEFT as Director of Operations. I think that's a good move for the system. Clearly it leaves us with a challenge, and we're just working through how, yeah, thanks Nick, how we fill that, but we've got some plans around that. And we've also got some vacancies lower down that we're just working through within the structure. In good news as well, two elements. One is that we've secured funding to continue access to Shrewd, which is a digital platform that enables real-time understanding of demand across the system and situational awareness of what's happening. So we use that within our control centre. And also, really good, section 3.3, the Ambulance Trust made available some non-recurrent funding to all of the 6 integrated care systems. And we put forward within SNE just under £500,000 of additional investment from both ESNEFT, West Suffolk Foundation Trust, and within our 111 provider. We were successful in getting all of that funding, and you'll see at Appendix 1 a list of schemes that we're now putting into place to give us additional capacity and resilience over the winter period. And then just finally at section 4.1, I think a development that we've picked up from Norfolk, so it's a good, again, the synergies and the good practice where we're sharing between the two ICBs, that Frankie and Lisa are now leading a clinical risk review panel that's taking place, I think it's fortnightly, is it Frankie? That effectively is bringing together key clinical leads from across the different partners each fortnight just to take a temperature check on how it's feeling and where we might need to make changes to kind of balance the risk that our different partners and providers are feeling. I think that's going to become even more important as we get more into the heart of the winter period. So, as I said, Chair, brief update, challenging, but our plan is in effect, and happy to take any questions other colleagues might want to add from their own perspective.
Richard, thank you very much, and thank you for that update following the, I think it was the September meeting of this board which approved it, and then NHSE approval thereafter. Update's really helpful. Shall I go down this side of the table? Looks like they're all on this, and Maddie over there. I'll just go down, Nick, if that's all right then. Should we go to Elaine first?
Thank you for the paper, Richard, and very thorough. My question is actually more about the social care side, which I don't know if we might need help from some others to help. There's a lot of prep described here in terms of vaccination. Is the same approach on vaccination happening in social care as well? So, for example, in care homes, residents and staff. That'd just be helpful to understand that side of it as well.
So if I start, and then I might look to colleagues who actually sat both to my left. So the vaccination is open for flu in particular to those aged over 65 and to care home and residential homes, and also frontline social care and health. So it's open, so I can start with that it is available, but colleagues might want to comment on Suffolk and Essex appropriately.
Go on, Clement.
Thank you for assurance. We are promoting the vaccination uptake and are working with the care market as well as social care staff to promote vaccinations.
Okay, and Moira's nodding as well. Okay, in which case, thank you, Nick.
Thanks. Just to come back on your point, if I may, Richard, yes, we are disappointed in terms of the offload delays on both sides, Ipswich and Colchester. We have bolstered now the senior leadership on both sides with appointments of site directors of operations. The Colchester colleague has started, and the sooner you can release Liz, the better for the minutes. Thank you. I think we've also taken a task force approach, so there are 4 major elements of concern at the moment across ESNEFT, one of which obviously is UEC and offload delays. So we've created a task force looking specifically at maximising the benefits of EPIC around flow, and particularly around, as one task force, another task force around finding ways to find alternative care, particularly for frailty. Not age-related, but frailty more generally. So I think that's really important. But also just to demonstrate the importance of system working here, I was alerted this morning actually when I was in the Ops Centre at Colchester early on, a 91-year-old lady in a care home who had a witnessed fall 4 days ago, bruising to the lower leg. Primary care was sent a photo. The feeling was they need to go to ED, despite a respect tool saying only for life-saving conditions. The GP insisted on transfer of the patient. The ambulance resisted. The GP still insisted. So the lady who was obviously a Cat 3 was woken up at 5 o'clock this morning, having been referred yesterday afternoon, brought into the A&E department, was seen by one of our senior doctors and discharged after 5 minutes. That can't happen. We need to learn from that condition. I'm sure everybody was making the right decision based on the information that they had available to them at the time. Is there a different way of providing care, particularly around care homes? So I think that's just because it's very live to me at the moment. So it's talking to the staff about it in ED this morning. So we are absolutely committed to improve the offload delays, because we know, and we've always said, whether here or indeed in our county to the north, that the patient at highest risk is the patient we haven't seen yet. So we absolutely want to free up ambulances. But this is a whole system. We will take our responsibility seriously. We will do our bit. But this is a whole system. So I commend the work that's going on at a whole system level.
Thank you for that. You very, very, very helpful reflections. Thank you. And I know that the points you made have hit home. I'll take it as rhetorical, though, Richard, if I may, and move on to Janet.
So my question was to ask for an update from Nick and you, and so half of it's been answered. So
it'll be so much better than
I'm
just warming you up.
You're simply moving.
How things are in West Suffolk, if we could.
Could I just hold you for a second, Ewan? Sorry, because Ed would like to come in topically. So
I'm just going to tee you up, Ewan. So data in front of me says that ambulance handovers have improved by 56% at West Suffolk from November 2024. So, really impressive progress. I guess the question is, what's happened?
Great. All yours, Ewan.
Yeah, well, I mean, as Nick said, UEC is a sort of complex system, and there isn't sort of one thing that fixes it. It's about delivering the optimal processes at every part of the pathway, pre-hospital, in the hospital, outside the hospital. Things are going reasonably well at the moment, but there are days when it is still particularly tough. But we've certainly seen over the last few weeks much better performance, both on ambulance handover delays and on 4 and 12-hour performance, but it's not fixed. We certainly had a very difficult period over the autumn. What we are seeing is that we're managing to improve performance on the previous year each year. So even when things are getting more difficult, they're better than they were the previous year. But it's a sort of daily battle across the entire system, and focusing on all the things within our control to try to make sure that the UEC care is delivered in a timely manner.
Okay, thank you. Let me just look down the table as I go round, and I think, Maddie, I'm coming to you next. All yours.
And it's just one sentence, just to confirm that we've also commissioned additional capacity in primary care for the winter period, and have, through each alliance, invested in the schemes that are in Appendix A as well, which enables them to be at slightly greater scale. Thank you.
Thank you, Maddie. Frida. Go on, Frida, and then I'll come to you, Maura.
I just want to take from Nick's example from this morning. I don't quite know, obviously don't know the detail, but I do feel that the neighbourhood model in North East Essex will address frailty, and hopefully going forward, if we can establish this model and get it up and running properly, then that would avoid those sort of things from happening. And that's why I think dealing with the top 5% is actually really important, because it does include frailty as a very prominent part of that 5%. And I think no, not in any way criticising anything else, but if you focus on one ailment or one chronic illness, then you sometimes can forget the biggest intake can be down to frailty.
Yeah, I think we're all agreed here. We're all on the same page. If we can get this right, no pressure, Maddie, life will be a lot better. Moira.
Thank you. Just wanted to note Richard's point about mental health and the challenges in the mental health system, because sometimes I think we talk about that through the lens of people coming into A&E, but not about the experience of people with mental illness and some of the significant delays in getting people into the right care in a timely way, and the risk that's held in the community when that happens. So significant amount of work still to do there. I just wanted to endorse that point. And just on Nick's point about, and Frida's point about care homes, got some really good examples of use of care technology in supporting kind of identification of falls and managing some of the risk around falls. So I think that's some really positive. I agree that's not an example we want to hear, Nick, but I think there's some really constructive work happening with our care homes in building an understanding of preventing falls and managing some of the risk.
Thank you, Maura. What I'm going to do, Richard, is I'll just come to Frankie, and then if I come back to you for final reflections on the overall debate. All yours, Frankie.
Thank you, Chair. I just wanted to echo Moira's point. In fact, the risk to people experiencing mental health crisis in the community awaiting admission is really very high on the agenda. In fact, it's the second highest risk that's come up through our fortnightly clinical risk review panel because of that balancing act we do every day, trying to find the right place for people who are struggling. And the right place is not the emergency department. It's not an inpatient ward. And it's also not at home. When these people really need help, we need to balance that risk and get it to them.
Thank you, Frankie. Richard, final reflections.
Thanks, Chet. Just briefly back on the mental health point. So one development, and it won't be in place for this winter, but it's a really good opportunity both in Essex and in Suffolk. There are plans to develop alternatives to ED provision, actually, helpfully, not very far from the Ipswich hospital site and on the Colchester hospital site. So effectively, rather than individuals with mental health challenges going into ED, and even if they are, they'll be routed directly through to those services, which is not before time, and I think a really good and far better model than we've currently got. So particularly in Essex, that will be in place, all being well, from the early part of the new financial year. I know Ewan's looking at me going, when's mine? Talk to your colleague on your left. And we are due to, I think, the capital business case is going through the process now for Ipswich imminently with NHS England. I was just going to come back to Nick, just a reflection as you were talking, and for all colleagues, if you've got examples that signify kind of a theme that you feel we should be looking into, let us know, because actually with that example, for instance, that shouldn't be happening. So is that if there are themes that are coming up, particularly through the clinical panel, we could talk about it there, or through the team that I've got, because those are the kind of things through winter then we can react to, and
so
it can help
direct
to
to
change
you,
our approach.
Richard.
I say yes, slightly hesitantly, but yes, that's fine.
Thank you, Richard. Okay, thank you for that, and thank you for the general action for all, direct to Richard. Board colleagues, we're supportive of the update and the progress. We note there's more to do. Everybody content to receive and note? Done. Thank you very much. In which case, item 10, please. Learning from Lives and Deaths, the leader annual report. And in Lisa's absence, Sarah, over to you.
Thank you, Chair. So, thank you very much to the Board for receiving the Learning from Lives and Deaths annual reports for 24 and 25. Although it's come to the Board for information, I'm sure colleagues will agree that this is really a significant and key report for all system partners. So I'm going to actually take the liberty of handing over to Wendy. Wendy is our Deputy Director of Nursing for Clinical Services and Learning Disabilities and Autism, and has been the co-author of this report. So it would be inappropriate for me to take the lead on this, Wendy. So I'm going to hand over to you, if that's okay, just to sort of cover some of the key points, if you don't mind.
No, thank you, Sarah. Thank you, everybody. I'm going to just pull out key points from the report. The report covers the period of 24-25, so we're always working behind, but also some of my reflections. I've been doing this a very long time. So you will see the number of people of deaths that we have reviewed, and you'll see that still we have people with learning disability dying 20 years younger than the general population. And I think I've been saying that every year for quite a few years. And you'll also note that the leading cause of death is respiratory conditions. So aspiration pneumonia in this cohort is absolutely the cause of death. But also this cohort have comorbidities that you have all spoken about today, as health inequalities. So this cohort have epilepsy, dysphagia, gastrointestinal conditions, hypertension, cardiovascular disease, COPD, mental health, diabetes, cancer. And they have all these co-occurring conditions, and they may have died from one of those conditions, but that doesn't mean to say that they've had the proactive care as other people may have, and that's what we pick out from LEADER. So we know about the life expectancy. One of the key deliverables for people with a learning disability is around having a good quality annual health check and a subsequent health action plan. And out of the 97 completed reviews, 90.7% had an annual health check. That's great. Our target is 85%. Well, our target is 100%, but well, I have to be a bit more realistic. But only 52.5% of people had a subsequent health action plan. And the health action plan is the detail of what needs to be in place to have your health needs met. I attended I'll talk about what I know as well. I attended a meeting yesterday with NHS England around what will be the key metrics moving forward with strategic commissioning, and they're spicing it up, as they said. So rather than having how many annual health checks, how many health action plans, what they want to know is how many at the same time, because it's a story that should be delivered at the same time. So there's a couple of patient stories in here. There's one around about a gentleman called David, and his sister really wanted his story to be shared with you. I'm not going to go into great detail, but just to say that David had multiple touch points with the system across health and social care, multiple. And his sister said it's gaps in service. I would disagree and say the service was there, but everybody didn't quite know what to do with David and get him in the right care at the right time. It may not have changed the outcome, but what his sister describes and what the LEADER reviewer found was he had a really poor experience of health and social care during the last 3 or 4 months of his life. There's a little bit of passing about services, I think. I also would like to, though, just talk about Stephen, because Stephen had a great experience of end-of-life care. Stephen was on the cancer pathway, who again had multiple touch points with lots of professionals who evidenced working really, really well together and had a really good experience of health and social care services and voluntary sector. So he had some care with the hospice. I don't think the hospice is voluntary, but you know what I mean, it's outside of the NHS label. We always try and show the good practice themes as well as the thematic learning, and in actual fact they sit hand in hand, because one person's experience could be good communication and another person's experience could be really poor communication. I think it depends on who you see on the day sometimes, so I'm not going to go into great detail. You will see how we've tried to achieve our agreed priorities over that year to try and address some of the health inequalities for this cohort to improve their experience. Some of them have been as successful, some of them we're still working through because actually they're never going to go away unless something significantly changes. It's a marathon. The Oliver McGowan mandatory training is red on here, but you have to remember this is the year before. And the code of practice for the Oliver McGowan mandatory training only got released in 25. I have to say the 17 and the 8% is probably because of ESNEFT. ESNEFT have been outstanding at being a really good partner to drive delivering the Oliver McGowan. We have more people now working with us. NSF, I'm pointing at Kath, NSFT, and West Suffolk are just beginning to join. But we still have quite a long way to go as a system. The reason this is red is because well, it's red because it's red, but we had to change how we were reporting what we were delivering. So the initial ask was that we deliver across health and social care, which we did, and we continue to do that because we didn't feel it was the right thing just to walk away from social care. I'm just going to talk about our priorities for this year, which of course we're already delivering because it's already 25-26. But when you work in the world of learning disabilities and autistic people, and you do a leader report every year, it gets a little bit disheartening, to be honest with you, because you keep saying the same thing, and you don't seem to make a significant impact. So what we thought this year was, right, let's do something completely different. Completely different. Let's be more proactive. Let's put all our energy into delivering what we've called Building Better Care Together sessions. Because it's not one person, it's a whole system. It's social care, it's families, it's people with a learning disability, it's our health services that all need to work together to improve the outcomes of people. So we've been holding them at Kesgrave, and we've held one every quarter, I want to say. And the ICB is literally a host. The ICB hosts the event and funds the event, which isn't a great deal of money. We have about 150 people attend, but the professionals have come from our system. So our professionals have come from ESNEFT, have come from West Suffolk. We had a whole session on aspiration pneumonia, which we did fund a private provider to come along. And at the end of the session, where we had ESNEFT's colleagues talking about the importance of physiotherapy, the importance of cleaning your teeth, the importance of oral hygiene, of food and nutrition, how to feed someone properly, they require feeding. At the end of the session, I asked 150 people in that room who had they ever had training on how to position a person, and not one person had. And yet, positioning, if you have a profound or multiple disability, regardless if it's a learning disability, is so important for prevention of ill health and aspiration pneumonia. And these are the people then rock up in A&E, and their journey is so far down, it's really difficult to turn it around for them. So we've done epilepsy. Joy, Andrew Kelso, who of course was with us at the time, attended and did a teaching session on epilepsy. And we know that the nurses from the hospitals attended and gave out and spoke about how to record epileptic seizures. So when you come to our clinic, we've got the information we need. We know people are doing it because we've spoken to them. Did you use it? Yes, and we didn't need to phone them and we didn't go in. So we know that we're making an impact, but it is a very slow burner. And my final point is the future of LEADER. So LEADER is not a statutory function of the ICB. And part of me thinks, but part of me thinks, well, maybe that's good. Because we know the information already. I don't have to go and review deaths to know where a person died, the age of the person, their comorbidities. I don't have to know whether they've had vaccinations and screening, because I've got population health management that tells me that. I know how many people have had an annual health check. I know how many people have had a health action plan. I talk to people in our communities all the while. So I know the information that I'm going to get. So rather than this reactive process, let's be much more proactive and continue with our partners delivering what we ask them to deliver, because we know that the information, free of charge, giving up their days. But it's been a journey, and my challenge to you all, especially you, Maddie, in the community there, is don't forget about this cohort. When you're talking about cancer, it's one of their, significant comorbidities. And that concludes my little rant.
Wendy, I don't think that was a rant. We've had some rants before. I think what came over to us colleagues there was the passion with which Wendy spoke, and also the commitments that she was asking for from us as a board, and some great key words in there, Wendy, as well, around the health action plan position, the multiple touch points, some positivity on the partner working, but still more to do. But great focus again on system and integration and partner working. So thank you for that. Elaine, I'll come to you first.
Yeah, so thank you very much, Wendy. I just wanted to pick up on this because we did cover it in the Quality Committee in October. And I think all of us absolutely felt there that that 20-year gap, we talk about outcomes today, that 20-year gap in life expectancy, it was just shocking. And as you say, it's been like that for a long time. There's been action plans in place. They've not shifted the dial. So re-emphasising, I think, the point Wendy's made beautifully, eloquently, but the need for kind of re-energising this work across all the partners is really important. The framework's there. It's about being more proactive, and there absolutely is an opportunity to make that change, but it does require everybody to lean in and help with it. So thank you very much, Wendy. Just re-emphasising.
And I think as a board we're saying yes to that, aren't we? Yeah? Thank you. Did you want to comment on that, Sarah, before I go to Janet?
Yeah, absolutely. So, I mean, I think we all completely agree in the room, don't we? And Elaine's point's really well made. So what we did discuss in the Quality Committee, particularly with Lisa Nobes, who's the SRO for this, was around we do need to do something different. We can't keep having the reports with the same recommendations and, as you say, not shifting the dial. So the action that we took quite assertively from the Quality Committee was looking at setting up a task force. But actually, again, as I said, looking at doing things very, very differently. So with all system partners there, yes, using the commissioning cycle with our strategic commissioning hats on as ICB colleagues, making sure all system partners are in the room to do something different, tackling this from a different avenue to the way that we had previously. So it was really just to underscore that that was the outcome from Quality Committee. Thank you.
Thanks, Sarah. A lot of nods around the table to Sarah's proposal there. Can we take that as a board-supported action and ask for a future update on progress on that, Tom, if we may? And Moira, is it on that subject, or shall I hold you? No, in which case I'll keep going if I may. Janet?
Thanks ever so much, Chair. I completely support what's happening here, and I was shocked that it wasn't a statutory responsibility. But that doesn't mean we shouldn't do it.
No,
and that's
so
absolutely, I would absolutely support that.
Yeah, so NHS England published, I think, on the 20th of November, a briefing, I think that's how they're describing it, reminding people of their legal duties in ICBs around reducing health inequalities. And LEADER is referenced, but the process of LEADER isn't statutory, but reducing health inequalities is. And this is about health inequalities of people with a learning disability.
Yeah, well, 20 years is a massive health inequality
it's
statistic,
huge.
isn't it?
It's huge, yeah.
Yep. Thank you, Janet. Oh, sorry, you've got one more.
My point was, I'm disappointed on the Oliver McGowan training stats there, but I appreciate you've put some context in that, because we've spoken about that. This is a board and partners many times and been incredibly supportive. So I just wondered if there's a sort of trajectory to give us some assurance that the red's going to turn to hopefully green, but at least amber.
Oh, we're a little bit amberish. The challenge we have is that not all of the partners in our system have signed up to deliver. So it's a statutory requirement, it's in law that people have to have Oliver McGowan. Well, don't have to have Oliver McGowan, but they have to have training on learning disability and autism. But as an ICB, we decided to support the system by having a training hub in the ICB. So it's delivered at cost price and we don't make a profit. And that seems to be a model that's working elsewhere now as well. Because it's much more expensive if you go and commission it yourself than if you get us to deliver it for you. So we're on a journey, if that makes sense. I don't think it's all Nick. I think it's his staff in this team. But Nick, ESNEFT have been great. West Suffolk have just joined NSFT. So we've got key NHS, but we're still missing. Oh, community dental services they have, but we're still missing some partners in that.
And we need to use our wider partners to encourage that, and I think we've all got a role to play in that.
Agreed, Janice, and I know Ed would like to make a comment on that, so over to you.
Yeah, it's just a little frustrating, isn't it? So what is preventing a partner in healthcare not wanting to do this training?
Well, social care are, because they're purchasing it from us. I think what's preventing the training is the narrative of backfill. And my narrative is no one's special in this. Everybody has exactly the same challenge, whether you're a health provider or if you're a really small learning disability social care provider. 30 people could be your whole team that you need to train. So I think that is it, though, Ed. It's the sticky wicket is backfill. But ESNEFT are doing it. West Suffolk have sorted themselves out.
Lots of hands on this specific subject, I assume, but maybe there's an action we could ask Ed for you to pick up with the team outside the meeting, because I can tell Ed's dissatisfied with this position anyway. Are you happy if we put that in the action?
Sure.
Thank you very much. I saw the hands raised, but you'll need to wave at me again. I'll stick with my list at the moment. I'll go to Kath, if I may.
Yeah, thank you so much. I think I commented the last time that this report was brought to board. I think that by continue to be shocked about the 20-year mortality gap, when this data has been known nationally for a number of years, we need to stop being shocked by the data and start being forced into action. Both learning disabilities is about a 20-year gap nationally. People with a serious mental illness, I have to say, about a 17-year gap. National data, we know this. So I think we need to take the position of we're no longer shocked, we're appalled, and we're going to act accordingly. That was my first comment. The second thing is with the Oliver McGowan training, NSFT has a 96.88% compliance with the Tier 1 training. It's not difficult, it's online, and over 4,900 of our staff are compliant with that training. So having aggregated data isn't helpful, because what it doesn't do is demonstrate where is succeeding and where isn't. So I think we probably need to now start understanding as a board where the data is, where the variation in that data is. And then the last comment I just wanted to make, the value and importance of people with their own lived experience, experts by experience, can be so impactful. So I wonder if the approach that we take, we just have to change, and for clinical colleagues, social care colleagues, everyone, need to be hearing from people with their own, who are experts by experience. So we've got to understand, what do we need to do differently? That is now going to make a difference, because the hearts and minds of colleagues clearly hasn't yet been affected. So we need to take a different approach. Thank you.
And I saw a lot of nods around the table to Kath's comments there. I'm going to take that as a board yes, and we'll put that in the action plan. What do we do different and better with better outcomes? Thank you, Kath. Amanda?
My point's already been covered, Chair. Thank you.
All done?
Yeah.
Moira?
Thank you. Wendy, thanks for your passion and commitment. I think you shouldn't be ashamed of that at all. I just wanted to say, really endorse the point of it's so vital now we're moving from health checks to health action plans, so we're really clear for the individuals what makes a difference. And I was appalled when I saw the data about respiratory being our main cause of death. That's absolutely preventable. But I also agree with you when there's some technical knowledge that people need to have about how best to support people to kind of eat and be positioned. So focus on that, I think, is really welcome. But it is absolutely preventable. People are dying younger from preventable things. And the final bit is the vital importance of reasonable adjustment. So actually our universal services, our screening services, are not sufficiently adjusted to meet the needs of people with learning disabilities and autistic people. And it's those relatively small things that make a huge difference as to whether people access services and get the support at the right time. So that's, I think, really important to focus on, that you know, these services are available, but they're not welcoming and open to people with learning disabilities and autistic people, and that's where it's falling down. And some of that's quite small things, not necessarily big things.
Thank you, Moira. Frida, and then Elaine, did you still want to come? No, you're done, so Frida.
Just from a primary care perspective, in terms of Oliver McGowan training, could I have is there data that I could have in terms of the training achieved in primary care?
I know the granular detail. I'm quite happy to share with everybody.
Is that all right?
Yeah,
because
absolutely.
I do get pushback from some of the senior partners on this in terms of capacities, you know.
Yeah.
Because I have pushed on it, and it is the length of the training on the second part that is the problem. The first is, you know, the second part of the day, and it, you know, I'm not making any excuses, but that's the pushback I get. So we did think about perhaps adapting it for a shutdown or something like that, if that was possible, and I just think there may be other ways of approaching it for primary care.
Thanks, Frida. Wendy, can we take that as an action that you and Frida will pick up to discuss outside the meeting?
Could I just update everybody on vaccinations, because we just so that you know the piece of work that we're currently doing. So Ace Angular in the Suffolk system is an advocacy service, and they got awarded some funding to build a campaign on raising awareness of the importance of screening it's called Screen Your Way to Better Health or something, with the sponsor of the ICB, so I sponsored it and chaired the meetings. And they've made videos because we can offer people, but they need to go, don't they? And so it's aimed at families, carers. Most of our people in our communities live with a carer who they rely on to take them. And we've had all the professionals across ESNEF, West Suffolk, joining that, and that's working really, really well. So hopefully we'll make an impact in the future.
Thanks, Wendy. And then finally, Richard.
I think firstly just to commend Wendy for the influence and the passion she's had regionally and nationally in terms of shaping this agenda. So she's an amazing colleague locally. We've got an opportunity with the commissioning strategy and the plan to really recommit to this area. So we'll come on later in the agenda, but if the board is keen to do something bold in this, we've got that opportunity with our commitment for the next 5 years, and I'm sure Wendy has got some ideas around what that could look like, but just think that could be an opportunity for us to signal what do we want to commit to over the next 5 years.
Thank you, Richard, and I think the board answer to that is yes, please. And then finally, Maddie.
Thank you. So I think there's 3 specific calls to action. So I think in terms of the health checks, I mean, you're right, the checks have increased and now we need to see the plans follow. So I think, again, maybe we just need to sit down and look at this really holistically with the primary care team and with primary care colleagues to work out what we need to do next to reach the same level of plans as checks. And as you say, we should be aspiring to 100%. In terms of the Oliver McGowan training, I was going to ask the same thing. And I think, again, maybe if we can sit down with training hub colleagues, LMC colleagues, GP Fed colleagues, Frankie, myself, and so we can really just step back and think, what is it practically that we need to do that would make the difference and change the position. And I have already just emailed colleagues to make sure that individuals with learning disabilities are included within the NNHIP plans, and I've copied you into that. So hopefully we can really look at how inequalities can be addressed within those programmes. Thanks.
Thank you, Maddie. So, colleagues, we were simply asked to receive and note this report. I think it's probably fair to say that as a board you have received and noted, but you've also set a string of actions and requests and requirements in place. I'm not going to go through them. I know Tom will have captured them all. I think we'll probably be looking for an update on those actions at some point in the future. Sarah, when would be realistic? 3 months, 4 months, 6 months? What would be realistic?
I think probably 3 to 4 months would
3
be
to 4
fine.
months.
Yes, I think let's keep the momentum going. I think
please.
is the reason why I'm sort of erring on that timescale.
Thank you very much. And Tom, would you kindly pop that into the forward planner, please? Okay, thank you very much. Thank you, Wendy. Yep, absolutely. All done. Okay, colleagues, we are 1 minute behind. I thought I was going to say that we were going to be ahead, but that was a really, really rich debate. Thank you for it. Let's move on, though, as promptly as we can to item 11, Work and Health Strategic Plan. Amanda.
Thank you very much, Chair. So I'm delighted that we are joined this morning by Helen, who has been leading this epic piece of work. And before I hand over to Helen, I'd like just to do a bit of an intro, if I may. So Helen is bringing together a 5-year strategic plan on how we can support people with health needs into work and remain in work. Helen has co-designed the plan with system partners and people with lived experience through a series of workshops and one-to-one discussions. And our ICB plan is aligned to the Suffolk Get Britain Working Plan, which links all National Department of Work and Pension plans and the 10-year NHS plan and Strategic Commissioning Plan. And finally, the plan will be implemented across our current geography, and post-April will be taken forward at a neighbourhood level, which will be co-produced with our local communities and system partners and embedded finally in our neighbourhood plan. So that was all I wanted to say by way of intro, but I know Helen is now going to bring together the strategic plan in more detail, and I'm sure we'll be happy to take any questions.
Thanks, Amanda. All yours, Helen.
Thank you. So, as you'll have seen in the plan, about 6% of our population in SNE are currently economically inactive due to health needs. So that means not searching for work when we use that phrase. So about a third of people that aren't searching for work, their health needs, disabilities are a barrier to them accessing employment. We're not alone in this situation. It's seen across the country and is forecast to deteriorate further. And hence the Get Britain Working Plan and last week the Keep Britain Working Plan as well, both white papers. All right, Nick. I thought you were going to say something, Nick, then, sorry.
Keep going, Helen.
Keep going. So last year, across SNE, our GPs issued about 150,000 fit notes to our population. And if we think around the sort of 8 to 10 minutes, that's about 20,000 hours of capacity from across our surgeries. And the prediction is that sickness absence rate will go up by 21% in the next 5 years. And we'll also see an additional 20% increase in economic inactivity. And as I say, health needs being the biggest reason for that. So our population are living longer, but we are more complex in our health needs, and majority of people that are out of work due to their health needs is because of comorbidities, so a number of conditions working together. And we see that very much within the 5% cohort that Frida was talking about in North East Essex. But we're also seeing those health needs coming forward at a much earlier age. So 1 in 5 children across the country have a mental health need. And we are starting to see a growing cohort of young people struggling to make it into their first job. So across the UK, about 3 million young people are currently economically inactive. And when we look at our young people in SNE, 16 to 24-year-olds represent about 2% of our population, but actually they represent 17% of the people in our area that are currently receiving personal independence payments. And that's not necessarily mean that they're out of work, but it means that their health needs are quite significant, that they need support to live independently. And the thing that worries me quite a bit is the statistic that our council colleagues has shared around in 2042, there'll be 1.1 working age adults in Suffolk for every child or retiree. So we need to be ensuring that we can help our working age adults be as healthy as possible so that they can make it into work, because work is a wider determinant of health, and good and safe, secure work improves health. So we know that those people that are out of work have a shorter life expectancy. So this is very much about how we can improve our population's health. So that's why it's called Fit for Work, Fit for Life, in terms of a life commissioning model of care, looking at improving our healthy life expectancy and reducing health inequalities, but for our whole households. Because if we see someone struggling to be in work due to their health needs, it does then have a ripple effect on the rest of the family's needs as well. So it's focused on helping people to get into work, but also remaining in work, which links across to the Keep Britain Working White Paper. It's a universal offer at all our population, but there are certain priority groups that we are focusing on. So the highest reason, a third of people who are out of work for health needs is due to a mental health condition, and then 14 to 15% with musculoskeletal conditions. But we also know that 50% of people with musculoskeletal conditions also have a mental health condition. They're quite often seen together. So we're looking at how we can support, say, our MSK physios to have better mental health understanding so that we can be making our every contact count with people and helping them to signpost them to the right services for their needs across the system. This is very much a multi-agency approach. This plan and the Get Britain working plans at a county council level are being developed as a triumvirate between ourselves, DWP and the council. And we are using the same ambitions and approach so that we can ensure that it's aligned across the whole system approach. So it includes around prevention, both primary and secondary prevention, and very much linking to what was talked about earlier in the neighbourhoods, early trailblazer sites. Early intervention about shifting our capacity where we can from reactive to a more earlier phase, so that if we can support people in the primary care space when they're first showing signs of ill health, then that should help us to keep more people healthy and in work. And looking at that multi-generational offer as well within a whole household. One of my main concerns is around that number of young people that we are starting to see to struggle to get into education, employment or training post-16. So there's quite a significant part of the strategic plan that is focused on our children and young people, helping them to remain engaged in their education. We're seeing, as I've said earlier, a huge number of children with mental health conditions, and working closely with NSFT about their mental health support team reconfiguration in the schools so that we can really optimise health and well-being. And our education partners have absolutely embraced this concept with working with them through the workshops, and we're looking at earlier detection of risk factors in primary schools, supporting the whole family unit with our services so that we can hopefully reduce the risk of young people struggling later on. Schools are open to having wellbeing hubs and further education institutions, and also trying to invite in the parents into that space themselves so that we can help them with their mental health needs or their work status. We're doing lots of small pilots at this stage using existing resources where we have them. So a social prescriber in the Haverhill Job Centre has been a really successful pilot to date, and we're about to publish the evaluation of that to see whether it might fit other systems. We're about to start a pilot in North East Essex, working with Active Essex, looking at a physical activity prescriber in that space as well, so that if someone's coming in for a fit note with maybe a musculoskeletal condition or even mental health, looking at how exercise might be able to help them and link in with other community assets. So it's not about necessarily working with our big employers. Suffolk and North East Essex actually are majority are small and medium-sized enterprises. It's a mixture of providing health checks, providing primary intervention, but actually bringing all of our offers together so that people can navigate the system much easier than is currently the case.
Thank you, Helen. And as we know, of course, having an appropriate job is the biggest of the many wider determinants of health on the Robert Wood Johnson model. It also plays heavily into the inequalities agenda, and with that, can I bring you in, Fanuel?
Thank you, Chair. Thank you, Amanda and Helen. I was quite particularly pleased to see this paper, particularly at this time with some of the challenges that we're experiencing. Firstly, it's quite important that we have acknowledged those challenges, but also we're thinking of doing something about it. I want to register my interest in this, given that we're actually doing work with young people on this. Some of the young people that we're working with are young people with experience of the care system, young people not in education or training, but also many young people who are in contact with the criminal justice system. By working across the system with local authorities, the voluntary sector, and also some of our anchor organizations. In terms of the opportunities that we have at this particular moment is that as the health and social care system, we have some of the biggest employers. So in terms of taking on some of these young people, there is a real opportunity. But we also know that maybe for the next 10 or so years, some of the biggest infrastructure projects across the country are going to be taking place on this patch. And so it's really important that we harness those opportunities, particularly for some of our young people. It's also quite critical that, giving young people jobs or apprenticeships or training opportunities is key, but it's about how we address some of the challenges that are stopping them from accessing those opportunities. So we've seen in many occasions where young people get jobs, but they don't stay in those jobs because employers haven't really addressed the challenges that young people are experiencing. So there are a lot of initiatives out there where you're looking at, before we even put a young person forward for an apprenticeship or for a job, let's address those issues and let's make sure that we're handing over to an employer a young person that is ready not only to get the job but also to stay in that job. And my offer is really, particularly with some of the strategic commissioning role that we're going to have, there is an opportunity again to focus on some of the social value that people need to evidence. And there is an opportunity here to look at some of the measurable evidence base that contractors or people that we're working with can sort of put forward, and we can leverage our role in that. I've also reached out and said I'm quite willing to work alongside yourselves on that. But also my offer to the board chair is that we work with some of the young people who are on this journey, and maybe the board could actually benefit from listening to the stories and the journey that some of those young people are going through, and I'd be willing to facilitate that.
So I'll come to you in a moment, Kirsten, if I may. Lots of nods there around the table, and from Helen and Amanda too. Can we take two actions there? One being, make sure you join up outside the meeting. I know you do anyway, but that we make the most of those opportunities. But then can we put that into the agenda planning for the, if you like, can I call it the young person's experience directly? So thank you very much. Thank you for that. Kirsten.
Thank you, Chair. Thank you, Helen. Thank you, Fanwell, actually, because I'm going to build on what you've said. Looking at a slightly different priority group, carers. So similar sort of thing to what Fanwell's saying. I think there's real evidence here that the voluntary sector can absolutely help with this piece of work and make a real difference to, prevention, health inequalities, etc. Suffolk Family Carers is working with employers at the moment. It's something quite new that we're doing in the last year to raise awareness of family carers, as there are 1 in 7 people employed who are family carers and who often leave work because they just can't juggle the caring role and work as well. And it only takes a little bit of creativity at work, a bit of flexible working, some sort of contingency planning, things like that, to keep someone in work and keep that family out of poverty or out of problems. We're working with Suffolk County Council on this. They've developed a really good award system called the Caring Companies Award that people can apply to, and that really encourages local employers to do the right thing by carers, change their policies, have templates, have support in place. And that could be an absolutely fantastic project, but the issue is resource, and it's probably the same with what Fanwell's doing. It could be really, moved to scale. I've seen in the report loads of other voluntary sector organisations involved in this sort of work. I think it is a case of bringing it all together and really providing some focus to it and some support to it, and really looking at the preventative element of it. We could really make a massive difference here, so I'd wholeheartedly support that.
Kirsten, thank you very much. And Maddie, and then, Frida and Moira. Okay, we're going to run behind if we're not quick, so let's keep the momentum
Very
up.
quick.
Go
Thank
on,
you.
Maddie.
Thank you. I mean, it's obviously a very significant issue. It's a very significant response that's been proposed, which I support. I think what we do need to do, certainly for our part, is to be really clear on which of these actions will make the biggest difference and which we need to do at which point in time as our contribution to this very diverse, very, very necessary set of actions. I think particularly, obviously, I'm saying within the neighbourhoods, we just need to be very clear so it maximises the outcomes. Thanks.
So focus and prioritise, Maddie. Is that your point? Frida?
Yes. Yes, just to say, anecdotally, I understand, but as a GP, I have noticed over my career the increased number of fit notes we are asked to complete. I mean, every morning I go in and there are a number, and then more young people asking for fit notes on mental health, stress, anxiety, in order to get benefits to help them survive while they can't find work. And I will say, I don't want to rant or be particularly political, but I will say that until we change the we improve economic growth in this country and change, and recent policies like the increase in NI for employers have reduced employment in young people. So whilst we can do as much as we can do, the problem is that the economics doesn't lend itself to employment of young people at the moment, without being political, so I apologise.
Thank you, Frida. Big picture point noted. And Moira?
Same point in children, actually. We know that a lot of children are coming through without having got qualifications as a result of mental illness because they're not at school. So actually that lifelong impact of not being able to get that first job, taking Frida's point, is so I think if we're going to focus anywhere, our sense is that children and coming out of school, particularly 14 plus, and what we found is that children in special educational schools are not being prepared for employment. What we're finding is that we're prepared to come into day services, not into employment. So the opportunity to kind of focus on again the working opportunities for people with disabilities is really, and we've seen some real success in supporting people with disabilities into employment, and that has a wide impact on their health and well-being.
Thank you, Moira. And again, you making the same points in so many different ways on so many of these subjects on the agenda, but system working, partnership working, so important, isn't it? One last one. Oh, you promised it's a quick one, Kath?
Very quick. It's a common. So this is a strategic plan, but it's massive. So how do we identify what might be, say, 3 priority actions that we can embrace and focus on, not for debate now today, but do think we need to try and make this deliverable?
No, thank you for that, and that builds on Maddie's points. Let's not put you under pressure now to answer that, Helen, but can we take that as an action to report back to the board, and we can do that in feedback, can't we? So, colleagues, we've got a whole series of actions there, but principally we're asked to approve the Work and Health Strategic Plan. Are we, with the actions we've agreed, happy to approve as is? Agreed? Lovely. Thanks very much, everybody. Now, item 12, which I was hoping to be able to build in a short coffee break for you after this item, so no pressure, but the 2025 ICB Cost Reduction and Transition Programme update. I'll go to Ed to say a few words and then over to Amanda.
I'll hand straight to Amanda.
Oh, you're going straight to Amanda. Thank you. All yours, Amanda.
Thank you very much. So, since we last discussed at a previous board meeting, there's probably half a dozen key points I would like to bring out of the paper. The first one being we have now commenced a considerable period of consultation, and that will conclude early January. And that consultation is to really primarily achieve our £19 per head of population from the 1st of April. As part of the consultation, we are working with our staff, our teams, and we truly are encouraging feedback. And as part of the consultation process, we have designed how members of staff and how teams can feedback. And we really do want to encourage as much feedback as possible, because we believe through that feedback we can actually help shape a better, perhaps, structure as we move forward. So that was the first point. The second point is referencing our staff. And since we were aware of the government changes on the 13th of March, we have continued to support our staff individually, collectively, through teams, and we have continually built a package of support, listening to what our staff's needs are, and that will continue because we think we cannot do enough to support our staff through these unprecedented times and changes. We continue to work with our trade unions. We have commenced that beginning of March, and that continues. And since we launched the consultation, the trade union engagement has ramped up to daily at the moment, quite honestly. We continue to manage the appropriate risks and mitigation, and there are a lot, and this plays into our board assurance framework, strategic risk number 34, which I'll come on to a bit later on. But we are very mindful that there will be a lot of risks that we do need to mitigate, and particular attention is on the supply chain as we move forward. All of the actions we have taken and continue to be taken will be reported through our relevant governance, through the risk and, well, the transition and merger committee, and will be reported to the board. So I'm going to leave it there, Chair, but very happy to take any questions. Thank you.
Amanda, thank you very much. And Janet, I don't necessarily want to put you on the spot, but from a transition committee point of view, do you have any comments you'd like to make as our rep on the committees?
So I think, thank you, Will. The transition committee continues to have a focused work plan around preparation for 1st of April and getting everything in place for that. It continues to focus on the potential risks and the mitigations of the risks, which I think is really important, and also continues to, look to wrap our arms around our staff and to give them the best support and the best opportunities to be involved in the consultation as they possibly can. We're also doing that through Remuneration Committee, which is now a joint committee with our Norfolk and Waveney colleagues, which is really important. We have got the issue of North East Essex staff, and I don't know, Amanda, if you want to just say a little word about their ability to be involved in the Essex ICB consultation, because I think that's a really important aspect of this to pick up.
Thank you very much, Janet. A very good point, and apologies, I may have missed that. So we obviously are working with our ICBs neighbouring Suffolk and North East at the moment, and we have been working very closely with Mid and South Essex ICB as they move into creating a new organisation from beginning of April. They are committed to ensuring that their consultation document, which is being consulted upon at the moment, is widely shared with all of our staff. We made that commitment a few weeks ago, and that will continue as we drive through the consultation period. We are listening to our staff, including all of our staff, quite honestly, and we have now started to increase the communication, and we're having more joint staff briefings with Essex. For example, yesterday we had an all-wide staff briefing. Ed and Tom Abel, the Chief Executive of MSC, they jointly chaired, and it was an opportunity for them to actually tell the story of what they're doing in terms of creating the new Essex organisation, but equally as important, inviting our staff's feedback. And there was a lot which we have taken and will be reflecting back through an FAQ, and we are committed to more of that continuing as we move forward the coming weeks and coming months. So we're very committed to working with Essex and our colleagues in help shape the future together. Thank you.
Amanda, thank you very much. Any questions for Amanda or indeed any other colleague? Otherwise, we're asked to receive a note, and no doubt, Amanda, we'll get a future update at the next board. Thank you. So, colleagues, with that, I've got 11:56 on my clock here. Shall we have a 10-minute break? Come back at 5 past. We'll be 5 minutes ahead, but we need to finish ahead if we can. So, 10-minute break, please. Thank you. Being prompt, much appreciated. We'll move on to item 13, research in primary care, and Frankie, all yours.
Thank you very much, Chair, and thanks very much for the opportunity to bring this to board. I'm really passionate about research, so I was really keen to really raise the profile of it. So, to start with, you might wonder why the Norfolk and Waveney team is referenced a lot in this paper, and that's because the Norfolk and Waveney Research and Innovation team is actually funded along with the Cambridge and Peterborough team to support research delivery in primary care and wider care settings. So our universities and our hospitals are well resourced, they have their own R&D teams, but other settings such as GP surgeries, also schools, prisons, social services and so forth are less well served, so that is its role. They support the research management and governance. They particularly support research in general practice, not so much pharmacy, optom and dental yet, and they are very well regarded and influential nationally. So where are we with primary care in SNE at the moment? Well, we have 25 practices, 10 clusters and 15 individual ones who are research active already. And they are packing quite the punch. So there are 6 ICBs in the east of England, and we are recruiting about a fifth of all of the primary care research participants in the east of England. So over 10,000 people over the last 3 years, which is pretty good going. Will be even better this time next year, but a pretty good start. We receive research capability funding, RCF, to build capability in research, and so that is used, we got 44,000 for SNE this year, and that is used to build capability, so providing training for GPs, but buying back that backfill time so that practice nurses can get their GCP to really build the research ability across our whole primary care. And we've actually been able to supplement that with 6 awards funded through SNE RCF, plus another 3 which we funded through some Norfolk and Waveney RCF. We are also on the cusp of getting even better, because nationally, the National Institute of Health and Research has funded 14 primary care commercial research delivery centres, and there are 3 in the east of England, 2 of which are committed to working with SNE. So we're absolutely well placed on that front. Our team is also just putting out its tentacles. We've held a lunch and learn for practices which do not undertake any research, so research naive practices across SNE. And we've also held a specific session for practices that are already in receipt of research funding. So that's really going great guns. It's not just about the researchers, though. It's also really important that your patients and public understand research, understand what it means to them, and understand how to get involved. And so that patient and public engagement, I think, is very strong in both SNE and Norfolk and Waveney systems. So through the carers' voices in research, we've been able to increase the relevance, the reach, and the impact of the research we deliver, particularly for underserved communities. So that's the highlights, but very happy to take questions.
Thank you, Frankie. That's a really encouraging report, isn't it? Let me start with Dave.
Yeah, thank you, Frankie. Really encouraging for primary care. Can I just make sure that it's high up on the Suffolk GP collaborative agenda, research, so please engage with those. I think they want to work with you and take this further.
Okay, thank you, Dave. I saw you nodding there. Do you want to respond to that, Frankie?
Great.
Yes?
Absolutely.
Okay, thank you. Just looking around the table. Janet and then Elaine.
Thanks, this is really exciting, and it's a real eye-opener and opportunity. We've got lots of other things going on as well. Maddie spoke today about the neighbourhood stuff. We know we've got the PCM pilots. Does any of this research work dovetail with those, or is it sort of sit separately?
A bit of both, I would say. So when we're talking about research, we're talking about, we need to be careful that we're not talking about service evaluations or quality improvements. So this is research in the true sense, and what I'm referring to in particular is the research that's nationally funded, because that's not only good for patient care, good for staff recruitment and retention, but it's also good financially. It supports those practices. So we have an evaluation team that evaluates the projects we're doing, but if it's a specific research project, then yes, absolutely it would.
So there's some overlap, but it's not identical.
Yes.
Okay, lovely. Thank you, Janet. Elaine?
So yeah, really good work. Thank you very much, Frankie, for the overview. My question is just really about looking ahead, particularly in light of the strategic shifts in the government, the 10-year plan, how you would see this potentially evolving going forward.
Thank you. So, firstly, when I'm talking about nationally funded research, of course, the research funded in the NHS is largely funded by, and so aligned with, Department of Health and Social Care. And as such, it issues themed calls. And so we then try and encourage people to respond to those themed calls. So 2 recent ones that I think you'd be pleased to hear about is one is early action to prevent poor health outcomes. And another one is supporting health, public health and social care workforce of the future. So again, really looking at how we can develop to deliver better. The engagement work, that research engagement network work that we do also tries to improve the relevance to the local populations. What matters to you is what we should be funding. And just picking up on that earlier conversations, particularly about the work we're doing in North East Essex, we are currently, the Norfolk and Waveney research team is currently hosting a national research programme called, rather splendidly called Splendid, which is social prescribing for people to live enjoyably with dementia and memory problems in daily life. That's the sort of research we're talking about. We're not talking about test tubes and microscopes. That piece of research is actually investigating whether a co-designed social prescribing pathway for people living with dementia is actually beneficial, because they sound great, but is there evidence? Does it actually work? And is it realistic? Is it implementable and scalable? So those are the sorts of research projects we really, really want to get behind and make a huge difference, I think.
Great, that's really helpful, thank you.
Yeah, thanks for the question, Elaine, and that response, Frankie, really helpful. Any other questions? Otherwise, we're asked to receive and note, and I think what we're probably saying as a board as well, received, noted, endorsed, and thank you for the progress. Keep going.
And perhaps, if I might be a bit cheeky, Chair, could we add it to the forward plan to bring our annual report every year from here on?
Oh, yes, absolutely. Yeah.
Great.
Pop that in the forward plan, Tom. Thank you very much. Yeah, thanks for that prompt, Frankie. Good. In which case, colleagues, let's then move on to item 14, the Green Plan. Amanda, shall I come to you? And I think you're going to introduce Andrew, aren't you?
Indeed, thank you very much, Chair. So here we have our Green Plan, which Andrew is going to talk through in a moment. But I'd like to actually say a few words on Andrew, who is an amazing employee, actually, and one of my trusted members of staff. Now, Andrew is the ICB Sustainability Lead and has introduced over many years and led and worked on numerous initiatives, including our air quality programme and inhaler switches, to name but a few. Andrew also represents the ICB on the Suffolk Climate Emergency Board and is chair of the Essex Climate Anchors Group. Andrew is going to now present what we have in front of us, and that is our Green Plan, which he has worked tirelessly on over many months, including that of system partners, because we, as a board, need to, along with other provider boards, sign off the Green Plan by the end of November. So we have a target which has been mandated by our regional colleagues, but that's equally fine. So without further ado, I'm going to hand over to Andrew, who is going to bring to life his epic work relating to our Green Plan. Thank you, Andrew.
Thank you, Amanda. Hi, everybody. Lovely to be here. And really, although it's called a Green Plan, it is in fact a sustainability strategy, unashamedly, that contains a Green Plan. And I was delighted to listen to various talks this morning that talked about health inequalities, the impacts of health inequality, finance, partnership, because our sustainability strategy absolutely encapsulates all of those elements. So I'll do a high-level run-through for you, and then an unashamed celebration at the end. And what started out as trying to pull a few case studies together that we could celebrate and demonstrate to staff their worth and what we'd all been doing in partnership ended up becoming a 25-page document as an appendices, and it's still growing because we haven't even added in all the work that the trusts have done yet. So without further ado, the strategy itself is built around the UN Sustainable Development Goals. So we're shifting the narrative away from it's all about net zero carbon to a wider sustainability agenda, which we've done through the duration of this Green Plan anyway. And the UN goals are in the actual Green Plan themselves as a schematic, and they absolutely recognise, there are 17 of them, that any global effort to eradicate poverty and bring health inequality and education and good care has to go hand in hand with a strategy that reduces climate change impacts and also protects the environment. As a really simple adage, there's no point building a factory to create work in a local area that then absolutely pollutes the watercourses and the air that people breathe. So it's a real holistic, integrated approach. So we're building on the steps of our first Green Plan, and you'll see in Appendix 2 that we've looked at the guidance that NHS England issued in February about what a Green Plan should look like, and we're really pleased because everything was green apart from one area, which was amber, and that was our work with primary care, which we intend to step up in this next Green Plan cycle. But that's not to say that we haven't done lots of work with primary care with our inhaler switch programme and other projects. So this is a refresh and an update, having assessed the Green Plan guidance. So what's the approach been? Well, being pragmatic and taking account of the merger with Norfolk and Waveney, and the fact that our first Green Plan was incredibly ambitious with 86 strategic objectives and key activities. We've condensed them down to 43, but some of them will still sit behind the work that we do, so it won't be lost. But it will make reporting easier, it will make visibility and staff doing the work easier, as well as the programme that I run. And it will also mirrors what's happened with the Suffolk Climate Emergency Plan, so condensing it down, and the Essex Air Quality Strategy, which I'll talk about in a moment. This has been reviewed with theme leads. We have 12 themes with East of England, NHS, and with our trusts, and our other key strategic partners and local authorities, public health. You'll see that we've got at the moment 50 contributors on the front there of people that have absolutely real system partnership working, pulling together what we're attempting to do. And I think it's really important to distinguish that this strategy or the plan is not just a regurgitation of what the trusts are being asked to do. This is about the ICB being a point of difference and using its role as a strategic commissioner and a partnership enabler in order to deliver sort of good health outcomes as well as environmental. So the goal, deliver sustainable value by reducing environmental and financial cost, whilst also maintaining or improving care, as well as delivering that wider social value. And we'll do that through looking through 4 sustainable care principles lenses. That's prevention, patient empowerment, being lean, and lower carbon alternatives. We've come up with a 3 up, 3 down outcome, which stemmed from sustainability impact assessment work that we did in the last Green Plan cycle. And by doing that, we encapsulate everything we need to do, but we're also then compliant with our statutory requirements in the Health and Care Act. I think that's really important. And we stress tested this with what staff understood and could actually remember and retain. So principally, the Health and Care Act stipulates that ICBs need to look to reduce carbon emissions, improve environmental performance, and there's 4 elements to that legislation. There's air quality, there's waste, there's nature and biodiversity. And I think I mentioned waste, I did, yes. And then the 3rd element is climate resilience, which I'll touch on in a moment. And that 3 up, 3 down then means that we're looking to reduce carbon emissions, reduce air quality emissions, and reduce waste, but also increase and improve nature, our resilience to climate change, and that wider social value through commissioning and procurement. It's an ambitious plan still, regardless that we've taken it down to 43 activities. The national guidance has 9 key themes. We've got 12 for SNE. So we've added in air quality. We've got a fantastic air quality programme where we've really integrated approaches. We have separated our waste because waste is intrinsically important to saving money and looking at resource pools when we do the work. And we've also hold on, I forgot my 3rd one. You'd think I'd know this off by heart
Right.
now, wouldn't you? So anyway, there's three extras: waste, air quality, and nature and green spaces. Sorry. So the actual strategy itself also looks at the sustainable care principles, gives examples, and it's really about anybody being able to pick this up and understand how all these complex areas weave together into an action plan. We are clustering with Norfolk and Waveney now, so both green plans have the same overarching strategic approach, which is sustainable value and all the steps that I've talked through. And in some of those areas, we're looking at the nature and green spaces work. That will now happen now for our Nature at Work project, which is a staff engagement project, looking at digital elements and some staff engagement. And the medicines management teams are already liaising on the inhaler switches and the formulary changes. And we will also look at an impact assessment piece of work, and the estates teams are also integrating as well. So the clustering is starting to happen. In terms of performance and where the previous green plan was, 65 are green on our RAG rating and 20 are amber. So I'm delighted with that because it was an ambitious programme. So just to sort of really summarise and just at the end, and unashamedly really in terms of celebrating what staff have achieved and what we can hopefully look forward to. In terms of the air quality work, our partnership work together has led to numerous projects on looking at indoor air quality as well as outdoor air quality, and that's hugely important as a health impact. We are two projects that we're working on now. One is looking at GP training to have a healthcare conversation with a very brief conversation supporting respiratory care patients and others. That's being done at Mill Road in Colchester. And on green spaces, we've got fantastic projects like the Royal Horticultural Society Wellbeing Garden at Colchester Hospital, as well as others. The anchors work that we've done in Essex, we will take towards Suffolk and Norfolk as well, which has been, we've put in there, I think we did 546 people across Essex had fuel poverty training to support health outcomes. We ended up briefing the chair of the Department of Net Zero on warmer homes and our approach to improving indoor air quality and how that could marry and support net zero and home improvements or insulational home improvements. And just to finish really, some other examples. The Green Light Trust is one example that we've put on sustainable models of care and into the appendices. And if you look at those 4 principles of sustainable care of repeat service users, being referred to the Green Light Trust, embracing nature, being outside, that helps patient throughput, that is prevention, it's lean because we're getting that throughput, and it's lower carbon. So the more social prescribing and the more integrated approaches we can do around that will reduce the carbon impact in primary care, where 60% of primary care carbon is related to prescription medicines. And just to finish, strategic commissioning is the nub of this green plan going forward really, and linking the neighbourhood teams at the coalface if you like, and making sure we take exactly what we was talking about earlier, really targeted approaches, so that when we come to design in those services through the commissioning process and get to procurement, we don't get to procurement and we just have questions about social value that offer, oh, what can you do for social value, but really targeted and really focused, hyper-focused on where we can really leverage local health benefits. So I think I'll leave it there, and open for any questions, and hopeful that you will agree and ratify so that we can publish.
Andrew, thank you very much. Do you just have a couple of words maybe to say on building on a common theme you will have heard this morning around partnership working and system working? How closely you work with our colleagues in public health?
Yeah, absolutely, Will. So the air quality approaches is one such. We started in Suffolk and ensured that we mirrored our approach with Suffolk County Council's air quality approach. And then unashamedly brought the Suffolk work to Essex and integrated the Essex approaches. So I've been chairing a subgroup within Essex. You yourself chaired an air quality summit that we had in Essex, where we had, I think, 89 different people. And so for the first time ever, Essex Council is about to launch its air quality strategy, but we've got complete alignment with 3 healthcare systems. Obviously it's going to be one going forward. All the boroughs, unitaries, districts, city together. And actually we've fundamentally shifted the focus through internal conversations away from just outdoor air quality and tailpipe emissions from cars to looking at indoor air quality and also looking at tackling health inequalities. So that's just one example of that integrated approach.
No, thank you for that. So, colleagues, any questions? Nick?
Yeah, we've heard a couple of times today about the impact of EPIC on patient care, but just a couple of facts. So EPIC in a year, because of the saving in carbon, will save enough electricity to power 100 homes, will save 1.62 million litres of water, and 2,170 trees.
Okay.
Already in the first 8 weeks of EPIC, we've saved 1.8 million sheets of paper being printed. Great. So we think about all the patient benefits, but there's a real bigger benefit to the carbon footprint as well.
Yeah, no, thank you.
There. Pretty impressed to remember those numbers.
Yeah, you did incredibly
Just nobody
well.
checked them.
We'll come back on that. Fanwell.
Thank you, Chair, and thank you, Andrew. I think today we've mentioned a couple of times as well the issue of using strategic commissioning, and particularly with the social value aspect. And what we've seen in the past is that, you know, some of the people that are, you know, sort of bidding for contracts might struggle to articulate what that looks like. Is it the intention that going forwards we'll be working with those potential bidders around, you know, what good looks like, or there's just an expectation that they need to know?
Most definitely. So we've done a very integrated impact assessment, sustainability impact assessment toolkit. And that was going to be used as the 4th national pathfinder type project for the NHS across the country to use the toolkit that we developed. The social value model changed in February, which surprised everyone, including the national team. So we've got to update that impact assessment. That's the next bit of work now. The Green Plan has come to fruition. And once we've completed that over the next couple of months, and there is a more integrated project going on to do that, we will go out, do market engagement, and absolutely, with the number of procurements and commissionings that we've reviewed now and seen, we can absolutely see with the impact assessments that if we get that right at the beginning, we can then drive a better social value output at the end. So, and I think I've assessed about 39 now, and I know there's more than that. So I'm pretty confident we know where the pinch points are, where the gaps in the market knowledge are, but I'll also be going to the voluntary community sector assembly to engage with them as part of this process as well.
Okay, thank you, Fanuel. If there are no other questions for Andrew, we're asked to ratify and approve the Green Plan. Is everybody content so to do? Resolved, agreed. Thank you very much. Thank you. Okay, in which case shall we then move on to item 15, which is sticking with you, Amanda. Actually, you've got a bit of a run of items here, haven't you? The EPRR item, all yours.
Thank you very much, Chair. So this is something that we are seeking board approval on this morning. But the report in front of us details the annual Emergency Preparedness, Resilience and Response Core Standards Assurance process that we have recently undertaken. And this year, our ICB has been rated as substantially compliant, meaning, or meeting rather, 44 out of the 47 standards in full. Several of our system partners have improved their compliance ratings compared to last year as well, reflecting progress in business continuity and response arrangements. The review process involved a confirm and challenge meeting with NHS England and local providers, and the outcomes will ultimately inform our system EPRR forum work plan for 25-26. So within the report, you can see actually where we have scored particularly well. And you will also note that we do have one provider with a partial compliant. And that's actually okay, because with regards to that, and NSFT, and Kath may want to say some more on that. So NSFT have given themselves a self-assessment of a partially compliant due to them taking part in a review of chemical, biological, radiological and nuclear policies and procedures. And that took into account recent learning from incidents from other trusts. This domain accounts for 10 of the 58 standards that they are required to self-assess against. But our EPRR lead is actually confident there are no additional patient safety risks present by this rating, and they have indeed a well-prepared work plan to address what they need to as the months move forward. So I just wanted to leave it there, but highlight a really positive outcome for our system, and we know what work needs to be happening with regards to NSFT. Thank you.
Amanda, thank you very much. Very positive report there. Frankie?
Thank you, Amanda. And I'm just going to share hot off the press. I had the Norfolk and Waveney check-in challenge with regional EPRR leads yesterday, and during that meeting, they name-checked the SNE EPRR team, saying, like Norfolk and Waveney, one of the smallest teams in the east of England, but absolutely leading the way and as a national exemplar. They also referenced NSFT as being the only provider in Norfolk and Waveney that's also amber, and they actually said, I think they've been rather harsh in how they've judged themselves. So I just wanted to endorse it, really.
Thank you, Frankie. Lovely. Did you want to respond to that, Kath?
Yeah, thank you. All I'll say is that Gary O'Hare, who's our new substantive Chief Operating Officer and the Emergency Accountable Officer, has come in with a fresh pair of eyes, and I think being self-critical, but then very confidently assured once we are able to declare appropriately that we are compliant. Thank you.
Thank you, Kath. So with that, colleagues, we are asked to approve the EPRR course standards submission. Everybody happy to approve? Done. Thank you very much. And Amanda, I think I'm sticking with you for the next item as well on Freedom to Speak Up, please.
You are indeed. Thank you very much, Chair. So this is our Freedom to Speak Up report reflecting Q1 and Q2 performance. This report was recently presented to our Remuneration Committee, and they felt it was rightly something that we should be presenting to our board, hence today. So if I just roll the clock back a year ago, we actually commissioned an independent service on Freedom to Speak Up by an independent organisation called the Guardian Service. That ran until, well, it's actually coming up for 2 years now, actually. During that time, they provided an independent service and probably saw around 8 members of staff throughout their time in contract. When their contract was coming to an end, it made us as an ICB reflect on their service, the cost effectiveness and the opportunity that we had as an ICB to potentially extend the current arrangements. And with that in mind, we actually commissioned another independent service from last April 25. And that service has remained in place to date, underscoring the independence, but equally, they have actually now, or we as an ICB, have extended that function and service to all of primary care across SNE. And that is at no cost to primary care. That has been well received, and to date you can see that we've had just a handful of queries, concerns that have been dealt with through the Freedom to Speak Up service, and all of the cases have been concluded to a satisfactory conclusion. We continually are raising the profile from within our own ICB and indeed across primary care, and I do know that the Guardian Service team frequently go out and visit general practice just to promote and remind them that they are there for their services should they require it. Going forward, we probably will see a spike in the number of concerns raised through the period of organisational change, but that will be played out in Q3 and Q4, no doubt. Going forward, I think we have opportunity as we look to create a new organisation, what opportunity there is to have a more blended approach in the way we deal with freedom to speak up. So that's something that we are currently considering at the moment. And as we move forward, that will be further discussed and debated, I'm sure, with our REMCO and ultimately coming back to the board for approval potentially. But I think it is good. It's particularly good that we do have that independent lens supporting our own workforce, but equally that across primary care. And I think we just need to harness that and continue to make that function there and supportive as we move forward. Thank you, Chair.
Thanks, Amanda. Janet?
Thank you, Chair, and thanks, Amanda. As Amanda said at the beginning, the Remuneration Committee have considered this and wanted to share it with the board. I think this is a great example of reviewing our processes and our approach to things, and it has improved value for money in that. The one challenge that we did give to Amanda through the Remuneration Committee was to try and get some feedback on how the service is now. We appreciate the numbers are so tiny, so it may not be something that we can do in the short term, but certainly something we would want to do in the long term to get some feedback from those that have spoken up and to see how their experience has been and whether we've been effective.
Yeah, no, good point on timeliness. Did you want to comment on that, Amanda?
I think time will tell, actually, and the numbers are very small, and I think there will become a moment in time as we move forward in potentially Q4 to really do a true evaluation, seeking feedback and appropriate feedback.
Can we, as a board, delegate that review to REMCOM? Yeah? Happy to do that? Thank you. Noted, Tom. Thank you. Dave?
Yeah, just a comment really from primary care, just a big thank you. Actually, this is a really vital service for primary care. It's something that's very difficult to do independently out in primary care for staff to be able to speak up confidently. So having someone independent within the ICB is extremely helpful for primary care.
Thank you, Dave. Thank you. So, colleagues, received, noted, and indeed approach endorsed. Everybody content? Great, thank you. In which case, item 17, medium-term planning update. Richard.
Thanks, Chair. So we've got a short paper in the pack which updates colleagues with the national expectations around planning, this time actually for the next 3 years, which I think the board would welcome as opposed to an annual cycle that we usually get. You'll see within the pack there's been a flurry of different documentation coming out nationally over the last few weeks and months. The first we got back in September was the planning framework for England, which was far earlier than we would usually get. If you recall, we usually get a flurry of documents on Christmas Eve, so we now had it at Halloween. And building out of that, we've also had then more detailed expectations and trajectories and guidance in October, and we've also had something called the Strategic Commissioning Framework that came out a few weeks ago, which is supporting us with our operating model locally as well. So what does that mean for us? So if you go on to page 4 in that paper, or 252 in the pack, you'll see the progress that we've made so far. So the first thing I just want to acknowledge is the huge effort and work that has gone in across both Suffolk and North East Essex ICB and Norfolk and Waveney ICB to, in effect, in record time, develop a new plan for the proposed Norfolk and Suffolk ICB, and also working with our Essex colleagues in a similar way over in Essex. So we're effectively bringing teams together for the first time to develop a 5-year strategy and a 5-year commissioning plan for those two proposed new organisations. I also want to say a huge thanks to our public health colleagues, again, across the 3 county councils who have worked together to produce integrated needs assessments for our population in both Suffolk, Norfolk and over in Essex. So effectively what we've done over the last, I'd say, month or so is firstly build that integrated needs assessment for our population. We've then taken that to effectively start to pull together a draft 5-year strategy, and then importantly a 5-year commissioning plan, which at its heart has a set of commissioning intentions for the next 5 years. Effectively, what are we saying to working with our population that we will deliver over that next 5-year time horizon, starting in April. We are due to effectively, well, we sent them out for comments, and most board members and partners will have got those on Friday from me. We've got about 2 to 3 weeks to comment back to the ICB, and then we're going to refresh and update and turn them fully into the strategy and the commissioning plan that we will bring through to the board at the January meeting to meet the national timelines, which are incredibly tight. So the expectation is by mid-February that ICBs in their new proposed formations, so Norfolk and Suffolk and Essex, will have both those key documents in place. Now, I recognise that given the amount of time we've previously taken, this is a much shortened time frame. So it's getting my excuses in now that it is a draft and it will need more work. And the approach for this year we will build on, obviously, from next year when we will have more time to do both of those. But I'm relatively pleased where we've got to in the time period we've had. And then running alongside that, we've got our more traditional planning cycle for the next 2 years. So we've got the financial allocations, which I'm sure Howard will update on later on in the agenda. We were waiting those, we got those last week, which has now enabled us to start the process of working with all of our NHS providers in both ICBs around what that looks like over the next 2 to 3 years. The big thing we've got to do by the 17th of December is our draft submission, is look at our workforce, our activity and performance, and our finances, and then triangulate all of that into one very neat package and pass that through up the line. Slightly tongue-in-cheek, because there's a huge amount of work to do in a very short space of time, but I'm confident, given we started earlier than some, that we're in as good a place as we can be to enable that to happen. So there'll be more at the board development session in December, and then we'll be bringing the final products through to the formal board in January. Thank you.
Thank you, Richard, and we look forward then to 16th of December, I think, the board dev, isn't it? Yes, thank you. Colleagues, any questions? Ed?
Yeah, well, thank you. I mean, you say you're relatively pleased where we've got to. My understanding is we're the most advanced ICB in terms of our plans and commissioning attentions and all of the work that's been put together. So that's a great tribute to you and all colleagues, and the public health teams have been absolutely amazing. Also, he referenced the strategic commissioning framework, and of course he was the author, so congratulations.
Yes, absolutely.
Richard, on that publication. Thank you.
Yes, the way Richard passed the comment, you wouldn't think, he didn't suggest that he'd authored it, did he? So, thank you, Richard.
We're playing that one down.
Thank you, Ed. Howard?
Seems like a timely place just to give early reflections, I guess, on how things are looking from a financial perspective. So we've got sight now the full planning guidance, as Richard has said, and also 3-year revenue and 4-year capital allocation. So that is a marked change from previous years. And that, as Richard said, also said, is for the new Norfolk and Suffolk ICB. I think it's fair to say that there is a really significant level of planning complexity this year, including the boundary changes with North East Essex that will require some careful planning and consideration over the coming weeks. The first submission date is due the 17th of December and the final on the 12th of February. And in my head, I'm really working to the 12th of February, if I'm completely honest, because I'm not sure we'll have gotten to the bottom of exactly how the funding should be distributed and what the position is likely to be by. I'm just sort of forewarning board, I guess, when we get to the 17th, there'll be a bit of a reality check on that. I think just to say some of the key highlights, really, number one, there is a return to organisational accountability. So that means that system control totals will no longer be in place from 26, 27. And again, that will feel very different as we get into next year. So the ICB board will only be responsible for signing off its own organisational plan, plus the assurance part on the respective organisational plans triangulating with each other. Allocations are planned to be moving towards a fair share over the planning period. That's very significant for the future Norfolk and Suffolk. It's about 100 million distance from target. I don't think that will be bridged in that planning period, but we'll be making that journey towards that which is, I think, a positive commitment from NHS England. We've also seen the reduction in the funding for the ICB running costs has been confirmed as £41 million. There is no lead-in for delivery of that, so that's just all coming out straight from the 1st of April, hence concluding those processes as well as possible is obviously very important. Importantly for Suffolk and North East Essex, we've now had confirmation that West Suffolk will receive deficit support funding next year, which I think is very positive, and generally speaking, deficit support funding for providers is going to be removed over the next 3 years, so that will taper off over that planning period. And I think the final thing to say is that there's also a clear move towards trust being paid on an activity basis as opposed to the sort of traditional block contracts that we've been, again, being used to. So, like I said, I think a lot of complexity, a lot of things to think through very carefully with system partners, but we will get there definitely by the 12th of February. I think it's what the position will be by the December submission, I think, is something we're going to have to take stock of through appropriate committees and so on. But yeah, there's a lot to go through.
Thank you very much, Howard, for that. So we're asked today to endorse the process within the time scales that have been outlined. We note that we'll be spending more time on it at the Board Development on the 16th, and then inevitably through the rest of December, January and into early February. All noted? No more questions? Good. Thank you very much, Richard and Howard. Richard, am I sticking with you for the performance report?
Yeah, I'll kick off, and then Maddie and other colleagues, I'm sure, will come in terms of their respective areas. So as always, if we start then just briefly on page 256 in the pack, which is the note from the Finance, Performance and Workforce Committee. So that just takes you through the main headlines of what we discussed and focused on through there, which is the governance structure below the board that oversees the performance. Howard's already touched, and we'll do later in the finance item. I'm sure Amanda will come in if needed later on workforce, and we also took some of the operational performance challenges, which takes us then into the next slide, which as always just gives you the headlines on the main areas in terms of our performance. So this is linked to the national standards, the national constitutional standards. We do look at other things, but this just gives you the oversight of the main national expectations. So just briefly, and again, I'm sure colleagues will want to come in later in terms of their respective organisations as appropriate. So on urgent emergency care, as we touched on earlier in the conversation around our winter update, our challenge remains our Cat 2, particularly over in Essex. But again, we touched on that earlier, and I know Nick covered some of the actions that are being put into place to enable that to improve, particularly as we're now into the winter period. But on our A&E performance, it has improved. It's still not where it needs to be, I think, as Ewan said earlier overall. But actually, it's in a better position than it was the couple of months before. I think over with elective and diagnostics, our challenge remains within diagnostic performance over at West. So we're in Tier 1, I think still Ewan around elective and diagnostics, but that's been reviewed. 2, sorry. I didn't know that, so hot off the press. So just for board's understanding, Tier 1 effectively is where national team are involved in the work that we're doing. Tier 2 is more of a regional oversight. But either way, effectively, there's more focused support and assurance in terms of a trust performance when they're in the tiering process. However, in terms of the data that we're more recently seeing, there is an improved position from the pack that you'll see in here. I think there's one particular area that's still off, but it's an improved position on the latest month compared to the pack you've got. But again, you might want to update further later on. Just to call out RTT performance at Esneft is in a good position overall. I think there's a couple where it's just slightly below, but overall it's tracking into a relatively good place. Cancer, we've got more challenges, I'll be honest, in both trusts. And again, Nick and Ewan might comment on, particularly around our 62-day performance over in Esneft. It's not quite where it needs to be, but I understand that at West Suffolk's in a better position. But faster diagnosis standard remains the area that we're particularly focused on, particularly in breast and in lower GI. In mental health, we're meeting 5 of the 8 national metrics. So there's a couple in particular where we need to focus more. One of them you won't be surprised, which is dementia diagnosis that I say every month. And the second one is we're slightly off track, as you'll see there, 1.4% on children's contacts, and there's particular work going in to try and resolve that. So although it's small, I want to nip it now before if it gets worse as we go through the rest of the financial year. And I'll come on to Maddie in a second around primary care. You'll see in the pack then, as always, we provide a narrative for each of the areas to go into a bit more detail. And just to give you the assurance, clearly through our existing governance, we've got a UEC, mental health and elective care group that oversees the detail and then reports to the performance committee. So I'll pause there. Thank you. Maddie, did you want to do primary?
Should we go to Maddie first before we come to Nick and Ewan? Yeah, over to you, Maddie.
Thank you. I'm not sure I can do that in one breath like Richard did, but thank you. So I'm referring to slides 258 and 268 and 269. So as you will see, the overall experience of access to primary care remains good, it's green, and the increase in the urgent dental appointments are also on target. I think this is probably an appropriate moment to reply to Mr. Ray's concern, if I may, which is about access to urgent dental treatment in Ipswich. So I'm very sorry to learn about the experience of your friend, and we will reply to you personally in writing. Overall, in terms of Ipswich, actually access to urgent dental care is improving and 50% higher than the England average. I think we've still got a lot of work to do to messaging about the access in those urgent times via 111. So we will continue to do that. We do still have work to do in addition in terms of prevention and in terms of planned dental activity. So, but we will reply to you personally in writing as well, Mr. A. Just also to note, as Richard did in terms of governance, that we continue to have the Primary Care Commissioning Group, and this is today across the whole of Suffolk and North East Essex, where we scrutinise performance further and look specifically as well at variation and how we can continue to support practices to redress any variation. Slide 270 also refers to community service rates. And again, overall, we're doing positively and well. There are some individual areas of service variation which do have support plans in place. So happy to take any questions. Thank you.
Maddie, thank you very much. Nick, shall I come to you first?
Not a lot to add from what I said earlier. We've set up tier 4 task forces. We're obviously a bit strange because, of course, we're having exactly the same conversations with region through their performance management, so probably not appropriate to go into too much detail now with their new role. Clearly disappointed on some of our standards. We've had a significant problem in terms of implementation of a new PACS system for radiology, which has proved less than perfect, and we're addressing that. But you know, we've got the task force around frailty, flow, cancer and diagnostics, and elective. So we've got some close targeted work in those areas and expect to see improvement into Q4. Thank you.
Thank you, Nick. Ewan?
Yeah, so just on the three areas, yeah, I mean, as we talked about earlier, you will see a significant improvement in 4-hour performance next month. We have been informally told that we're stepping down from tier 1 to tier 2 on elective and diagnostics and out of tier 2 for cancer. So some really good progress across the board.
Yeah, noted. Thank you very much. Colleagues, any other contributions or comments received and noted? Much work to do, as always, and thank you to everybody who is contributing to the progress made thus far. But this is a long job, isn't it? In fact, a never-ending job, I'm sure. So thank you to all. With that, received and noted, we'll go on to finance report. And Howard, all yours.
Thank you, Chair. So a reminder, SNE NHS system has a plan to spend £2.8 billion of allocated revenue in 25-26. That represents an overall break-even position, which includes a £20.7 million planned deficit at West Suffolk Foundation Trust, offset by an equivalent surplus at the ICB and a small contribution from East. A reminder also to the board that whilst system control totals, as I advised earlier, won't be in place from next financial year, they are absolutely in place for this financial year. So we're still mandated to deliver our system plan in this financial year. As of the reporting period to October, that's month 7, the system is currently £6.9 million in deficit, but £2.2 million ahead of what is effectively a £9 million year-to-date deficit plan. So we're slightly ahead of that plan. That, of course, does suggest that plans are heavily weighted towards improvements in the latter 5 months of the year, which is, of course, mainly the case in West Suffolk and Esneft. Of the system organisations, the most significant risk currently resides with Esneft. The trust is currently running at a year-to-date deficit of just over £10 million, which is £5.8 million worse than planned, with a high risk now of not delivering against its planned break-even target. It should be noted that Esneft, of course, has an excellent track record of delivery, and at this point we believe this is a non-recurrent issue for this financial year related to some of the very significant developments that the Trust has undertaken. And we've obviously heard about EPIC through the course of this, but there's also been the Orthopaedic Centre and some other developments. There are active discussions ongoing with the Trust, and I would expect any decisions on changing for planning targets for this year to have concluded in December at the Finance Committee in December, and coming to board for sign-off if that's where it's heading. For the other system partners, I think it's very pleasing that they continue to track well against plan, with particular credit to West Suffolk for being just under £3 million ahead of their plan for the period to date, which of course is a marked improvement on the previous 2 very challenging years. And the ICB has also had a particularly strong year of SIP performance, that's cost improvement planning, sorry, with a notable grip on continuing healthcare prescribing, and we were very early in implementing for the shift to using contractual levers for activity planning. But we're actually currently forecasting 133% delivery in year against our cost improvement plan. That's 6.6 million ahead of a 20 million plan, so a very positive position for the ICB. In summary, Chair, I think the SNE system is on trajectory to deliver its plan for this financial year, but there is a considerable headwind that we need to navigate with respect to the Esneft forecast in particular. Before I end, I just need to update the board on the implementation of our new ledger system. This is the new Oracle Fusion Finance System, sometimes known as ISFE2. It went live on the 1st of October. And unfortunately came with some critical defects, including hierarchy bugs, multi-organisation access flaws, some reporting inaccuracies, all of which has created a risk to paying suppliers and staff on time, and also meeting our statutory financial reporting requirements. I just want to say we're obviously escalating to NHS England and exec level. We're taking the appropriate papers and positions through audit committees. This is really a national issue, so it isn't something that's just affecting SNE or indeed Norfolk and Waveney ICB. It's a national issue to do with the implementation of the ledger. I think I'm just highlighting that there is a potential issue as we get through production of accounts, particularly when we get to the end of the year. But a word of thanks really to the finance team and obviously all colleagues in the ICB for working through the issues, again, none of which is in our own making, but we are escalating as appropriate. I'll pause there. Thank you.
Thank you, Howard. And that latter point about the ledgers, I saw Janet and Chris, you both nodding, so it's on your respective committee agendas. And from the board's assurance point of view, you've got it. Great. Thank you very much. Frankie?
Thank you. I just wanted to reference the industrial action, which hasn't featured very much in our discussions today, but from a quality and safety perspective, clearly this is a huge challenge, and I think as a system we've sort of gone above and beyond to make sure we keep things as safe as possible from an emergency care perspective, but also limiting its impact on elective care, but that does carry a financial cost. And I just, I don't know whether that, I suspect that will have contributed to some of the challenges that our providers.
Yeah, and also thank you for the thanks as well to those who've delivered. So let's emphasise that from a board point of view. Do you want to comment at all on Frankie's financial point?
Yeah, Frankie is obviously completely correct. IA has caused financial pressure, there's no doubt. And at the moment, there's no sign of national funding for it.
No, that's inevitable. Extra pressure in every way. Thank you, Frankie. Any other questions or points on Howard's financial performance report year to date? So we recognise the challenges. Thank you for the progress to actually, because it's an all job, isn't it? So thank you to everybody in the finance team, of course. Shall we receive a note and move on? Everybody's so happy. That's good. Well, the next item, and thank you, Maddie and Fanwell, we know you've got to go to another meeting. Item 20 is the ICP update, which Susanna can't give because she's had to give apologies today. Tom, shall we take an action to ask? I'm sure Susanna will be very prepared to give a short written update that we can circulate. Shall we do it that way? Okay, in which case then move on to 21, the governance handbook and constitution item. Amanda?
Thank you very much, Chair. So this was partly discussed at our September board, and we agreed that we needed to take a little bit of action in terms of how we manage our governance through our transition period. So that has resulted in our governance handbook and constitution being updated, and there are two components of that. The first relates to the joint executive team we have now working across both of our ICBs. So the handbook now reflects who those executive directors are, their job titles and areas of responsibility. And the second was around really how we are going to be supporting the transition as we move from current to the creation of what will be, we think, an Essex ICB once legislation takes into account early next year. So with that in mind, all three ICBs responsible for delivering all things to Essex have actually agreed, and the formation of an Essex Joint Committee has been established so that we can still deal with our responsibilities that we need to as an ICB, but also supporting Essex as it moves forward to the 1st of April. So the joint committee is reflected in our handbook and the constitution, and the terms of reference are appended as well. The joint committee had its first meeting last week in Essex, and a couple of our board members were present representing the ICB. We may or may not want comment from those members who attended, but by all accounts, as a first meeting, it was successful. So I'm going to leave it there, Chair, but these are the changes required as we move into transition, and then obviously there will be a requirement that we have to create a new constitution as we move forward, which indeed will come back to a future board meeting.
Amanda, thank you. Janet, were you saying you wanted to come in there? Yep, please do.
Yes, so I was at the Essex Joint Committee last week, and it was really agreeing the governance and the way that we're going to work together going forward. I think it's really important to note, after our conversations at our board last time, that we now have a primary care representative for North East Essex on that board, and Frida has taken up that mantle. And I think that was us influencing, you know, the constitution of that committee. So I'll keep board appraised. They're going to meet every couple of months, and it's, you know, we'll see how it progresses.
Thank you, Janet. And Frida, thank you for doing that.
Yes, I missed the meeting actually, just to be clear, but I will be at the next meeting.
Okay, thank you. Any questions or comments? Otherwise, we've got 2 recommendations which I think we should go through and governance-wise approve. First of all, we're supporting the changes. Are we supporting the changes to the governance handbook approved by the Chair in consultation with the Chief Executive and Chair of Audit? Approved? Great, thank you. And then we request approval from NHS England to amend the Constitution to reflect the changes in executive titles. Everybody agreed? Wonderful. Thank you very much, everybody. Thank you, Amanda, but I'm sticking with you for the BAF, please.
Thank you very much indeed. So here we have our November Board Assurance Framework, and as we will see, we have no new risks added this time. We are still managing our 16 strategic risks, which are managed by an executive director and then played through the appropriate committee where there is check, challenge and updating accordingly. Now, we had a new risk at the last meeting, the September board, and that was referring to all things EPIC. And as we have heard through the duration of our meeting this morning, the EPIC rollout has been successful, work continues, but we have had oversight through the Strategic Diagnostic Investment Committee, I think the SDAC, and that is recommending to the board today that given the progress and the oversight that committee has provided, that we should actually remove the EPIC from the BAF today, but it remains on the Directorate Risk Register so that we keep a watching eye as we move forward. So that is something I would be recommending to the board. And then with regards to Risk 34, which I briefly mentioned earlier on, that is with regards to how we're managing our current transition. This very much is a live issue that we continually are updating actually as we move day by day. And as I said earlier on, we do need to be particularly mindful of the mitigations pertaining to the risks, particularly as we move into the consultation period. So I think that's probably all I want to say, Chair, but fellow director colleagues may want to add a note or 2 on their current risks. Thank you.
Thank you, Amanda. Nick, are you okay? Are you supportive of EPIC removal from? Yep. Yep, good, noted, thank you. Any other questions or points? Kath?
Yeah, thank you. I appreciate it feels like probably about 3 weeks since the last board, but I think there's some updates that are needed for the mental health risk in terms of progress that we've made. So probably outside of the meeting, we probably need to go through that from an NSFT perspective. Thank you.
Go on, Amanda, yeah, please.
There was one particular point that I forgot to mention. I do apologise, but I just wanted to reference, which is indeed within the report. As we are now working more closely with our colleagues in Norfolk and Waveney, we are actually now starting a piece of work to align both board assurance frameworks and doing a comparison of different approaches to risk. So that will only strengthen as we move forward. But I felt it was important for board colleagues to be aware of that.
Thank you, Amanda. Yeah, good points. Ed, and then Howard.
Just to support Kath's point, I was in an assurance meeting yesterday and going through the NSFT data, the progress is very strong, and that's triangulated with views from the public, the MPs, mainly stakeholders, so it's really pleasing. Yeah.
Thank you, Ed. Howard?
Yeah, just to note that Strategic Risk 25, this is the ability for the ICB to meet its financial targets, does need an update. So again, apologies, that should have happened by now, but we'll be running that through the December Finance Committee.
Okay, so can we take that as an action? Amanda, would that come to January board? It seems a long way away for that. Should we do an electronic? Would you be okay with an electronic circulation once the review's been done? Are you okay with that as well? Absolutely. Let's take that as an action. Otherwise, it's 2 months away, isn't it? Okay, thank you. Any other comments or points, Dave?
Chair, it may not be appropriate at this stage. I just wanted to, ESNEFT and EPIC essentially. Actually, you know, I think as a system and the primary care absolutely see the benefit of what ESNEFT have been doing, but I just wonder about the impact on other partners within the system of this change and what we as an ICB have learned from that, because I think there will probably be another trust that goes through a similar process, and how can we mitigate the knock-on effect that it inevitably has on other stakeholders within the ICB.
Yeah, that's a good point, isn't it? Can we take that? Oh, go on, Frankie.
Just to provide you some reassurance, Dave, we actually brought a paper yesterday to our exec management team to look at the lessons and learning from EPIC implementation. So we are cited and have a whole raft of learning.
Would it be appropriate to bring that, even if it's for information, to a future board once completed? Are you happy with that, Frankie? Yeah? Shall we agree that? Happy with that, Dave? Yeah? Good. Thank you for that contribution. Good. Anything else on the BAF? Otherwise, we're approving the changes as documented and agreed in discussion. Subject to updates, by the sound of it. This is a continuous process, isn't it? All agreed? Lovely. Thank you very much. In which case, item 23, which is the committee and highlight reports. Now, there are 6 reports there. I'm tempted to go straight for questions unless anybody would like to raise any issues, or any of the chairs, that is, would like to discuss any of the reports. No, in which case, any questions? Otherwise, received and noted. Done. Thank you very much. Attendance log, again, for noting. Received and noted, unless there are any questions. Done. Any other business? Now, none has been notified to me prior, so I'm just looking round the table. Now is your opportunity to wave at me if you have any. No other business. Good. In which case, let's move on to questions from the public. And Simon, I think you very kindly offered to read out the questions that we have from members of the public who aren't here today, and then we will go to the appropriate exec to answer that question. So, over to you.
Thank you very much indeed, and good afternoon. The first question we have here is from Mike Hope. He's written the following: I see Dr. Ed Garrett has got on record as saying that NHS contracts with the US tech data giant Palantir for a federated data platform should be considered on their merits and have nothing whatsoever to do with assisting Israeli genocide in Gaza. I note that this is not the view of very many clinicians locally and nationwide who consider the ethical stance of Palantir to be lethal and refuse to engage with it. Can Ed or others confirm as to whether Palantir's joint offer with Multiverse of data apprenticeships for NHS staff, seemingly to encourage take-up of the unpopular FDP, has been received by the ICB or the trusts, and whether there are any plans for local NHS staff to engage with this.
Thank you, Simon. Amanda, am I coming to you for this one?
You are indeed. Thank you very much. Thank you for the question. So it is our understanding that the apprenticeships mentioned in the question will not be launched until next year, and we as an ICB currently have no plans to launch them locally. Thank you.
Okay, thank you, Amanda. Back to you, Simon.
Okay, the next series of questions are from Anthony Dooley. There are 3 questions which are new and 1 that was rolled over from the previous meeting. He's also submitted some statements as well, which I think we're going to note. Is that correct, Chair? So the first question from Anthony Dooley. Why do the minutes not make explicit the reason that the board recognised the tensions in the country and the impact this was having on staff? Will you make a statement condemning those politicians and others who have stoked racism and commit to opposition to that racism by issuing a public statement from this meeting? Further, you state your response to the proposed so-called anti-racism online training for all NHS staff that claims that the definition of anti-Semitism includes criticism of Israel, that is responsible for the genocide in Gaza and the murder of more than 250 Gazan civilians since the so-called ceasefire.
Okay, and Ed, I think I'm coming to you to respond to that, please.
It's a similar answer to previous questions. It's not within our scope to talk about international politics, no matter what our views might be privately. At the start of the meeting, we did, however, receive a letter on anti-racism, which we talked about with great commitment and passion, and through Amanda's office, we are taking forward appropriate actions. So we're very understanding of the issue, and we will make practical attempts to tackle the issue locally, but what we can't do is issue statements on international politics.
Thank you, Ed. Back to you, Simon.
The second question from Mr. Doody then. If Mary has not addressed these in her information, could she state her understanding on how in implementing the Neighbourhood Health Programme finance will be raised, particularly on the possibility that the government will resurrect the disastrously expensive PFI approach, even if it uses different words? You know, if it's quack likes a duck, etc. Also, who are considered the stakeholders in this process, and what will be the process of engagement?
Okay, and who's picking that one up?
Can I suggest that Maddie sends Anthony an email?
Would it have been for Maddie?
Yeah,
Yeah,
it's for Maddie.
Okay, can we... yes, shall we do a written response on that one? Yeah, Maddie's had to leave to go to another meeting. Yeah. Okay, thank you. Thank you, Ed. Back to you, Simon.
Okay, the third question from Anthony Dooley. Could Amanda set out how the social determinants of health are to be addressed in the health strategic plan, given what we know about their importance, as Marmot has reported twice? I am, of course, referring to the need, for example, of affordable social housing without issues of damp, etc., and the other social determinants of health.
And Richard, I think I'll come to you.
So I'm going to channel my inner Amanda, so hopefully I do this justice. Good point, Anthony, in terms of the question you've raised. I think the original Marmot review and then the follow-up in 2020 shows clearly that health inequalities stem largely from how people are born, grow, live, work and age, and that's a point that we've made many times in this board and through the work that we've done. And particularly drawn to the Marmot 6 core policy objectives, and when you look at those, 3 of them are absolutely going to be linked through to our plan that I talked about earlier, our commissioning plan, particularly around giving every child the best start in life, ensuring a healthy standard of living for all, and strengthening the role of ill health prevention. So for those 3 in particular, they're absolutely covered within the emerging plan that we've got. And for the other 3, they will be part of our 2 county-based neighbourhood health plans that will be overseen by the Health and Wellbeing Board. So I'm confident that we will be addressing that through our work. But as always, Anthony, you'll see the drafts, and if we are missing something, I'm sure you'll let us know and we can address that.
Thank you, Richard. And one more, Simon, have you got?
Yes, there's one more, which is a question rolled over from the last meeting, and it's as follows. Now that the UN has declared Israel's actions in Gaza as a genocide, would Nick Hume like to show similar emotional intelligence and sensitivity towards staff at SNF by following Caroline's lead and emailing all staff? One of his staff has a brother in prison for nearly a year as one of the Filton 18, for example.
Thank you. Nick, did you want to respond to that?
No, I won't be emailing all staff. I don't think it's relevant in my post. Thank you.
Okay, thank you very much. And now, are you going to Mr. Ray's question?
I think Maddie addressed that.
Maddie covered that in... yes, she did, of course, didn't she? Is that all done? Did any questions come in? No, during the meeting? None? All done? Okay. Lovely. In which case, everybody, thank you very much for being so prompt this morning. So it's just coming up to 1:20. We've got a private meeting to follow. I suggest we have a 10-minute break and reconvene at 1:30 in private session. The next meeting of the board in public is on the 27th of January, and I look forward to seeing you all then. Thank you very much, everybody. Thank you.